Good morning, everyone. Good morning. I want to welcome you to the Blue Ribbon Study Committee on Health and Healthcare Oversight. I thank you all for being here today. I'm going to ask Chairman Taylor to open us in a brief word of prayer.
Thank you for bringing us together today, and let us use our wisdom and discernment as we work for the people of Georgia. Help us to understand what is thy will. Guide us in the right way. We ask these things in Christ's name. Amen.
Amen. Well, thank you all for being here. Obviously, health and healthcare oversight and the role of the state is a large one. And that is the reason I appreciate the speaker appointing this excellent committee for us to get together. We do have a couple more showing up a little bit later, but it is summertime and we all have our regular lives and jobs that we're working to do, but we're here to serve the people of Georgia. And so I would like to go over real quickly, just a little bit of a landscape, which is what we're going to get today from some of our wonderful departments and commissioners in different areas on the role of healthcare. Obviously, to each of our citizens and to each of our families, healthcare is crucial. A little over 60% of Georgians get their healthcare insurance coverage, and we will in these meetings differentiate between insurance coverage and actual healthcare. Sometimes there is a difference, but over 60% get it through their employer. But about 2.1 million Georgians, a lot of our age, blind, and disabled, and low income, and a lot of our children get it through the generosity of state taxpayers and those of us that they've elected to represent them. A little over $9 billion of Georgians' tax money goes toward health care. That's about 24% of the budget of all the taxes that we raise in a year. Almost a quarter goes to help provide health care for our fellow Georgians, for the Georgia share. Now, if you include the federal money that's overseen by many of the departments that we're going to hear from later today, that number is over $30 billion and about 41% of the total spending that the state does of both combined state and federal money. So you can see how important it is to Georgians and their elected representatives that we commit this degree of money, that Georgians commit the income taxes, gas taxes, everything else that comes into the state budget. But this is a tremendous and a very important part of our budget. And we're going to hear from some of the organizations, the committees and the commissions and departments that help us deliver the services that are needed. But one of the other things we're going to hear is some of the legislation that's been passed over the past 6 or so years, where we've tried to gradually, as we come back each year, try to improve the way the services are delivered. It's not just the money that the state spends. The state also has a role, along with the federal government, of making the rules on how competition exists, on how prices are done. Obviously, Medicare rates are set at the federal government level. There's nothing individual states can do about that. Hospitals have to make up some of the losses on federal programs with what they charge in commercials. So, those of us in the legislature and our department friends also make a lot of the rules that private entities have to go by, hospitals, healthcare practices, and others. So we want to make sure that in addition to the part that the state funds, that over $9 billion or over $31 billion total dollars is spent wisely, but we also want to make sure that we have ground rules that encourage the best outcome in both affordability, access, and quality. And so those are some of the things. It's a broad mission for this Blue Ribbon Study Committee, but we have some very able members. We did want to start today with finding out a little more about that $9.1 billion or $31 billion number that is spent through our state departments first. So that's a little of what we're going to go through today, and we're going to hear from several of the organizations the departments that are tasked with delivering that service, to looking at healthcare access, healthcare affordability, care for some of the neediest Georgians. We're going to hear first from the Georgia Department of Behavioral Health and Developmental Disabilities, for example. That's one of the departments to where we're helping with a big challenge. Many of you know the House Bill 1013 passed several years ago. That was a goal for us to make sure we have put together all the tools necessary to take care of some of our mental illness challenges, whether throughout the state of Georgia, including addiction and many other problems. So I'm looking forward to getting us started with that. We are going to, I believe, I do see Commissioner Tanner here. So with that, we're gonna jump right into hearing from our departments and let them give us an overview of what's going on now, what's been going on and changing in the last few years, and a little bit of an understanding of what their department does and how the guidelines that we have set will handle it. So, Chairman Tanner, yeah, come on up to the podium, or you have somebody who's going to help you on your. All right, if you could just, for those who don't know you, introduce yourself, and I think either of those mics works. Check that out.
Thank you, Mr. Chairman, and to the committee for having me today. Got the opportunity to serve with a lot of you on this group, and I appreciate your leadership of what you've done in the past and continue to do for our state. For those who don't know me, I'm the Commissioner of Georgia Department of Behavioral Health and Developmental Disabilities. Had the opportunity to serve 8 years in the Georgia General Assembly in the House, a total of 36 years working in public service in different capacities. I also have the honor of serving as the chair of the Behavioral Health Coordinating Council, which has been in existence now for quite a while. Also the chair of the Behavioral Health Reform and Innovation Commission, which was created, legislation started in the House in 2019, and that has really been able to create some momentum, I think, in the state. And I'm also the trustee of the Georgia Opioid Crisis Abatement Funds. So I wear several hats, and I appreciate the opportunity to be here with you today to try to continue to improve services in this system, behavioral health, IDD, and addiction. I do want to just acknowledge the fact that we have an agency that has a lot of boots on the ground. We're going to talk about that, and we have a lot of people who help make me look good every day, and I want to thank our staff for all they do all across the state. I also want to thank the governor, the First Lady, and the General Assembly. You all have made historic investments over the last 7 years into the behavioral health system that's really making a difference on the ground each and every day, so thank you. And then I want to talk a little bit about our mission. It remains the same as it always has, but I think what's changed is our approach. We're trying to build a system that delivers services closer to homes so people are able to remain in contact with family, their faith community, and support networks. We provide most of our services through our network of providers. Many of you are familiar with community service boards. You know what those are. We traditionally had more. We had around 26. That number is now down to 22. By the end of this year, that number will be down to 18. We've consolidated some of those because it's been very difficult financially for a small community service board to be viable. So we've been able to work with some of our community service boards to agree to some mergers, and excited about that. We're really improving that system. We also operate 5 state hospitals. We have a hospital in Columbus, one in Milledgeville, one in Savannah, one in Augusta, and one here in Atlanta. We also have 5 regional offices around the state that serve the state, and we have regional directors in each of these offices, and we have a deputy assistant commissioner north and a deputy assistant commissioner south who's based in Thomasville. I know Representative Chairlady Taylor is very familiar with her and her office there, and the most southern part of the state you can get to. Since 2019, we've had some major milestones in legislation thanks to many members on this body. The chairman mentioned the Year of Mental Health in 2022 with the Parity Act that Speaker David Ralston championed his leadership, along with Chairman Todd Jones and Representative Mary Margaret Oliver, really working hard on that. And that really was the beginning of a tide shift, I think, in Georgia. That same year, we saw Senate Bill 610 pass. That requires a provider rate study every 4 years to strengthen the behavioral health workforce. That's something I encourage you to keep your eye on the ball. We had gotten so far behind in our rates in Georgia, that the workforce was struggling. So there was a commitment made to do a new rate study every 4 years. And I can tell you, as someone who assisted drafting many of those pieces of legislation, the intent of that was from the time the other rate study was done 4 years from then, not necessarily when it was implemented. So I think that's important for us to stay up to date on providing the correct provider reimbursements. Also, Senate Bill 403 passed that year. That was the co-responder bill. I can tell you, as someone who ran a law enforcement agency, co-responders has been one of the best things to happen to our law enforcement communities in a long time. And then just this past year, 2025, House Bill 268, championed by the House, dealing with school safety, dealing with behavioral health in schools. And then also House Bill 584 in 2025 passed. That transitioned the oversight of drug treatment programs and community living arrangements from DCH over to us to have a more streamlined process. And then this past session, Senate Bill 535 passed. Now, that transitioned community service boards and made some significant changes to community service boards. Community service boards are separate legal entities in Georgia, but they were created by the state. Their boards are appointed by the local governments in the catchment areas that they serve, and then they traditionally have hired a CEO to run the community service board. The state is a big funder of the CSBs through our agency and have a great deal of oversight. But what we have found was, depending on your zip code, you got a different level of service. So in an effort to streamline that, with the governor's support, Senate Bill 535 passed, and that was effective July 1st. So now the CEOs have transitioned over to be state employees, and we have the ability to create a standard set of bylaws that all CSBs have to adopt. We're also going to be in the process of standing up a medical committee that will be chaired by our chief medical director that's going to look at creating some overarching protocols across the whole network. If you look at some studies and dealing with, because the people that I get calls about and you get calls about typically have schizophrenia, medication non-compliant. One of the best things that we can do is have a good system of care through the whole healthcare system for those individuals. So I think by the changes we're making in the community service boards, you're going to see significant improvements in that area over the next several years. They also, since 2019, the governor and the General Assembly have appropriated funds for both the behavioral health side and IDD side at historic levels, and we're continuing to see major progress. And I think a big milestone was reached in February of this year. Many of you know Georgia has been under a DOJ settlement agreement for 16 years, since 2010. And in February, both the DOJ, the court monitor, us, and a federal judge agreed and signed an order releasing us from all 60 provisions of the behavioral health settlement agreement portion, replaced it with one provision, which has to do with housing, that requires us to house an additional 541 individuals, 404 of those being from the Georgia housing voucher. You all funded those 404 housing vouchers. And I'm happy to tell you that before the end of this year, we will have the DOJ monitor back on site, and we will have met that condition, and the entire behavioral health side of the settlement agreement will be over. We still have work to do on the IDD side. We're actively working closely with DOJ on that. We're making a tremendous amount of progress in that area. I would like to pivot, though, to probably what you hear the most about as a legislator, and that's the forensic population. Those are the calls you get from sheriffs and judges and others, and their concern. We're responsible for several areas there. First of all, if the court believes that someone's not competent, they do an ordering us to do an evaluation. We send one of our psychologists out, licensed psychologists out, to do that evaluation, make a determination, do we believe the person's competent or not? If they're not competent, do we believe that they can be restored through treatment? And we send that report to the court. In the past, we were getting quite a few people who were competent, and sometimes we saw that it was just a delay tactic. So you all passed some legislation a couple of years ago that requires that a hearing be conducted prior to that order, and that has made a significant difference. But we are seeing our incompetency findings increase. In FY23, it was 38.4% of the people we evaluated were not competent. In FY25, it was 42.5%, and I believe we're going to see that trend continue. We also have to restore those folks to competency. So we get orders to restore people to competency, and that's when they're ordered to come to the state hospital. The other type of forensic patient we get is when the court's made the determination this person's not guilty by reason of insanity. Those people are ordered to the state hospital for treatment. On average, those individuals stay an average of 8 years, but we have people who've been there 25 plus years. A lot of that has to do with the serious nature of some of the crimes that they originally committed and the court's reluctance to let them out. So the JRC, Jail-Based Restoration Facility in Dodge, is something that you all helped us with. The Department of Juvenile Justice had a facility down in Dodge County they were no longer using, so we went down and took a look at it. You all provided some funding. We redid the facility and turned it into Georgia's first standalone jail restoration facility. We opened that in 2025, and we've restored 89 individuals there with an average restoration time of 71 days. In the hospital, it takes typically over 160 days to restore someone. So we're having really good success with the jail-based restoration facility. We operate the security side through our police agency that the department has, and we operate the clinical side. So this is not, we have some partnerships with jails. This is not one of those. We operate the total facility. And we also created a new program called Operation New Hope. Those of you who were here in 2022 remember when House Bill 1013 passed from the rostrum, the speaker said, "Today hope won." So we took that kind of as a rallying cry, and we recognize that we have people in the state hospital who have been there a long time, who our doctors believe are clinically ready to get out, but the court's reluctant for them to be released. So we have stood up, with your help, in Savannah, Milledgeville, and Columbus, Operation New Hope programs. Those are beds that are the state's first transitional type beds for this population. These are typically individuals who have been in the state hospital for a long time. They go into Operation New Hope. They move into a facility that looks more like a home than it would a hospital, but it's still on our campus. They're able to go get GED training, technical college training, job skills training, life training. Some of these individuals don't know how to wash clothes. Some of these individuals don't know how to balance a checkbook. We teach them those skills, and then they're allowed to go out and get a job if they're capable of doing that. And ultimately, the goal is they can step down into a community-based program. So we've had good success with that so far, and we're continuing to grow that program. Why that's really so important, other than the fact it's turning lives around, it opens up the bed for someone else who's stuck in jail to come in. So the individuals who have been there for 20 years have been keeping a bed tied up that now is going to be vacant, that we can typically turn over 2-3 times a year. So that's a big improvement. The biggest investment that the state's made is into a new mental health hospital. In the last mental health hospital the state built was in the 1960s. Georgia had a little over 4 million people in the 1960s. We have close to 12 million Georgians today. A certain percentage of the population is going to have serious persistent mental illness, and we're going to need to be able to take care of those individuals. You all budgeted $409 million to build a 300-bed hospital. I'm happy to say that we have a close working relationship with GISFIC, who is responsible for construction projects for the state. We already have the architect on board. We already have the contractor on board. We expect to have a ribbon cutting or a groundbreaking in November. We expect to start turning dirt in January. We're going to release some early packages so that we can get this thing going. Our hope is to have it operational in 30 months, which is going to be quick for a 300-bed hospital. I've got a lot of people in jail that need a hospital bed, so we're excited to get this going. The hospital building, our hope is, will also be a place of learning. We've been having conversations with some schools about embedding a nursing school program inside the hospital. We also are looking to create a psychiatry residency program inside the hospital, also a forensic psychiatry fellowship program there. We also we moved some dollars around internally to hire a research director. That position will be hired within the next 30 days. And we're going to be doing research and publishing on some of the work that our staff is doing to really lead. I think we will be able to lead the nation in some of the work. This facility is going to be a cornerstone for that. So we're very, very excited about where we're heading. The crisis continuum over the last several years, we have set out to make the crisis care as easy as possible for people to access. Hopefully everyone in this room has heard of 988. 988 is a game changer for the system. That is the easy button to access care. Last year, we received over 350,000 calls, texts, and chats in Georgia to 988. We're now averaging around 1,000 contacts per day from different individuals across Georgia. We dispatched mobile crisis services to over 1,700 people every month last year. We connected 50,000 individuals to crisis beds last year through 988. That's an average of 4,200 per month. Mobile crisis, if you're not familiar with that, if you call 988, you're a parent, you have a child who is having a mental health episode and you need help, we can dispatch a 2-person mobile crisis team to your home anywhere in the state of Georgia. And typically they arrive within 1 hour, depending on traffic, et cetera. They can go anywhere. They can go to the side of the road. They can go to jail. They can go to your home, wherever they need to be. One of those individuals is a licensed clinician. That person has the ability to do 1013s. Our mobile crisis teams have the ability to transport individuals to crisis care if they need that level of care. We also, through your help, continue to build out our crisis center network across the state. One of the things the Behavioral Health Reform and Innovation Commission recognized early on is we didn't have enough crisis beds, and we didn't have them necessarily where they needed to be in our state. We just opened a new behavioral health crisis center in Augusta just a couple months ago. We have one that just finished the design and is about to be under construction in North Fulton. We have another one that's going to be, that the land has already been purchased. The design is about to start in Clayton County. That'd be the first in Clayton. It's right across from Costco in the city of Morrow. This is going to be a unique facility. The plan is for it to be 30 adult beds and 16 child and adolescent beds. We'll be able to serve everyone in this building from 5 years up in the same on the same campus. We also will have what we call temp op beds. It'll also have a robust outpatient component, and it'll be open 24 hours a day, just like all of our new BHCCs are open 24 hours a day. That means law enforcement, a parent, someone can drive themselves there. They can get treatment. They can see a provider 24 hours a day, 7 days a week at these facilities. Now, we also have one under construction in Dublin that's going to open later this year. The new child and adolescent facility is under construction. It'll open in January down in Savannah. And our hope is to continue to partner with you all to build out that bed study that we did. We have some older crisis centers in the state. I know Chair Lady Taylor and I've had conversations about hers in Thomasville that we'd like to be able to replace. The good thing about that is we don't need as much annualized funding. Some of those are one-time funding options that we need to just build a new facility. But we're excited to move that forward. I'll also tell you that studies have shown that by providing crisis services, it can save $2 to $3 in hospital costs for every dollar we spend on crisis care, because we keep people out of the emergency room. We keep also people out of jail. The other thing that I want to mention to you, and this also is down in the southern part of the state, we heard from sheriffs how they're tired of doing transports on 1013s, especially when the person's not under arrest. It's just somebody that a judge or a doctor has done a 1013 on. So we started a pilot program a couple of years ago. We did a study first down in the southern part of the state, southwest Georgia, and then we went in and we purchased a van for Georgia Pines Community Service Board, and they're doing the transports. So they do the transports on 1013s for multiple counties in the area. It's working extremely well. It's working so well that when the Rural Innovation dollars came out, we worked with DCH to get that written in. and we're about to expand that to Northwest Georgia up at Highland Rivers with a plan to expand that across the state. So I can tell you, Sheriff's going to be extremely happy if we're able to make that work. That'll become a Medicaid billable service. Oklahoma has done something similar. Oklahoma's a lot smaller than Georgia, but it has worked extremely well. The other thing I want to mention to you hear a lot about is the Now Comp Waiver Services. That is a Medicaid waiver that we provide to individuals with intellectual developmental disabilities. Our Now waiver supports 4,500 individuals. The Now waiver is less costly, but it's individuals who are able to stay in home, in place with some additional supports. A comp waiver, we have nearly 10,000 individuals on that currently. That is individuals who need community-based care, a host home, etc. Last year, we enrolled an additional 854 individuals into waiver services. You see a line item in the budget every year for additional Now comp waivers. That's what we're talking about here. We have what we call a planning list. Some people call it a wait list. It's not a wait list, it's a planning list. But that planning list has almost 8,000 individual names on it currently. Those are individuals who have been deemed pre-qualified for a Now Comp waiver. Some of them need a Now Comp waiver now. Some of them are receiving services through other sources like the Department of Education, but we know at some point in their life they probably will need a Now Comp waiver. We've worked closely with an IDD work group that we established made up of advocates and other experts to create a new assessment tool. That tool is currently being validated by the Ralston Institute at the University of Georgia. Once we finish that and run everyone through that tool, it will divide the planning list into 3 groups: immediate, planning, and forecasting. The idea there with the immediate is I can tell you when we're talking about the budget, this is how many people out of the 8,000 need a waiver now. So what that number will be the one that you will want to consider. Then we'll have the planning, which will be these individuals will need a waiver within the next 2 to 4 years. And then the forecasting is 5 years plus. But I think it's important for you as appropriators to know what to plan for. It's also important for us and our provider network, because I don't want to have to staff up for 1,200 waivers this year and then next year only get 100, and I've got to figure out what I'm going to do with these staff members. Our provider network needs consistency. So our hope is we can get that with this new tool. We're modernizing the system and continuing to be more responsive. And then our complex care for these individuals, we typically have between 15 and 25 individuals stuck in an emergency room every day that has intellectual developmental disabilities. These individuals are high end of the spectrum with needs. Last June, we opened the state's first crisis service and diagnostic center in Macon. This is really something unlike anything in the entire country. It is a 16-bed inpatient facility to stabilize individuals who are high-need individuals, typically stuck in an emergency room. It really helps fill a critical gap in the system and is working extremely well. But these individuals don't stay there permanently. They come there to get stabilized. So in order to figure out how do we step individuals down, we piloted 2 homes in Augusta for high acute individuals with IDD back in 2024. Since opening those homes, we've been able to reduce the backlog in emergency rooms by 40%. We're in the process right now, under construction. We already opened 1 additional home in Macon. We have 2 more in Macon under construction. We also have 2 in DeKalb County that's about to go under construction. We've already purchased land in the Savannah area for 2 more. We have a plan to build 2 additional homes in Gainesville and 2 additional homes in Albany. But our goal by the end of the year, we'll have 20 of these high acuity beds in 5 residential specialized settings open. Once we get this network built out, our hope is it'll be on autopilot so individuals don't get stuck. We're able to move them to the right setting. But all of that's underway, and it's thanks to the support and leadership from the General Assembly. Another thing that you hear a lot about, and Chairman Hawkins and I talk often about this, and that's dental care. We're really challenged with dental care for our population for a lot of reasons. But we had been in the process of purchasing a mobile dental clinic when the Rural Innovation dollars came available. So thanks to our partners at DCH, we've been able to partner with them to utilize funding from that grant. That mobile dental clinic has arrived, and it is going to be on the road providing mobile dental services. We'll be able to go to a day center for those with intellectual developmental disabilities. Will be able to set up the dental office there and see patients so they don't have to travel. So we're extremely excited about that. That will become a Medicaid reimbursable expense. The program will launch at 12 rural locations, and we expect to expand that to 24 sites. That's going to be based out of the Augusta area and traveling in that area. Dr. Kimberly Cole, who has served this population for many, many years, who retired from us and agreed to come back to run this program, has a heart for this. This is something she's pushed for and talked about for many years. And we're excited about this partnership. The other thing I want to mention to you is workforce development. One of the other things we saw early on in the Behavioral Health Reform and Innovation Commission was we can have all the great ideas in the world, but if we don't have the workforce, nothing's going to be possible. That's the reason the rate study was so important. Implementation of that was so important. You have to pay a person a livable wage. But we have quite a few individuals that work for us. During COVID, our hospitals lost a tremendous amount of their workforce and had to take a lot of beds offline, and we've been able to build back from that. But we have recognized we're going to have to build and create our own workforce. So we have a lot of partnerships underway currently. We launched a tuition for service partnership with Mercer University School of Medicine and St. Francis Hospital. Really excited about this. This should start. We'll be approaching the students in fall, enter into contracts in January with the first year starting next year. This is going to be an accelerated medical school program. It'll go from 4 years to 3 years. They'll have to go in the summer. They'll take the full 4-year curriculum in 3. They automatically match with St. Francis Hospital in Columbus for their psychiatry residency. They'll do 4 years of residency there, and they agree to work for us for 4 years when they graduate. We're excited about this. Dr. Morton and his team, our medical director at our Columbus Hospital, have a great relationship with Mercer in Columbus, and that's where we're going to be kicking this program off. We also have created a partnership with Mercer's psychology program here in Atlanta. We are getting ready to sign the first 3 contracts with the first 3 students who are in the program. They're getting their PhD in psychology, and they'll agree to come to work for us after they graduate. They also agree to do their internship and their postdoc with us. And we have such a shortage of psychologists in Georgia. There's only 11 approved internship sites in the entire state. One of them is our Atlanta hospital. We have a consultant on board now working with us. We're going to look to expand all of our 5 hospitals to approved internship sites in the future. We have got to build out our psychologists here in the state of Georgia. We're also partnering with Augusta University to create a similar partnership with the dental program. We have a shortage of dentists that will agree to work with our population. It's very difficult for us to get the dentists to work for us, so we're going to create our own program. We also have what we call Apex Climb. You're familiar with the Apex program in schools. We have a tough time, our providers have a tough time getting clinicians. So we're funding 20 social work graduate students every year. They agree to work 2 years in a Apex school up on graduation. So we're continuing to create opportunities and partnerships to develop our workforce. With that, Mr. Chairman, again, we've made a whole lot of progress since 2019. None of it would have been possible without the leadership of the House supporting these efforts, asking tough questions, providing funding, passing pieces of legislation. But your work is paying off, and it's going to continue to do so.
Well, I want to just on behalf of the committee and frankly, Georgia, appreciate your work, but also I know it takes a team, and
Yes,
and it takes everybody a little bit of time to build a team. You've obviously built a high functioning team. Your comments bring up one of the things that we really were hoping to see a little more about today from all the presenters. I know you mentioned workforce there at the end. Well, after lunch, we hear from the Georgia Board of Healthcare Workforce. So we have 2 different departments doing that. You mentioned some dental work and maybe some other advantages and programs that you're working on that will eventually become Medicaid reimbursable. Well, that's going to be administered through the Department of Community Health, who we'll be hearing from next. Even the Department of Corrections, when you mentioned the challenges with both our jails and prisons and the challenge with forensic institutionalization. One thing I'm hoping our committee can understand better is, number one, the degree of coordination that's required. I know at your opening, you mentioned several titles you have. I'm assuming some of those boards have members of other departments potentially, or at least other interested parties. We want to make sure we've encouraged and built the framework and frankly the funding when it's needed for Georgia taxpayers' money for all our departments to work together, to not duplicate services. But sometimes it sounds like you've had to start up a program knowing that eventually it'll be covered by Medicaid, but the early dollars, I assume, flow through your department. Is that correct?
Yes, a lot of the work we're doing that I mentioned with the rural innovation, that we have received funding through DCH has received funding and partnering with us, like on the mobile dental clinic, some of the other programs, the transport program, where we're going to demonstrate that it works with the hope of being able to receive ongoing funding through as a Medicaid reimbursable expense. Now, the workforce pieces we're doing obviously will not transition to Medicaid. Those individuals we're creating will come to work for us, and they'll be state employees. So that would not be something that Medicaid would cover.
Well, obviously, some GME funding helps with some of that as well. Right. But I appreciate you pointing out the areas where the silos don't exist, or at least are defensive silos, to where our departments are working together and transitioning when needed to, and that's just an encouraging piece of it. We've got about 5 minutes for questions, up to 5 minutes. I'm going to see from Chairman Taylor. Oh, I'm sorry, Mitchell.
Okay,
sorry.
Thank you, Chairman. I want to join Chairman Newton in publicly stating, I think it can't be stated enough publicly, of the tremendous job you and your team are doing. I'm completing my 24th year in the legislature, and I will tell you, I could tell you some horror stories, but you have done an incredible job, and I want to say that publicly. That being said, under access to care, reduction in wait times, like to address that, I hear often from constituents, rural and underserved communities access, do they receive the same kind of access as some other communities? And do you have an idea the number experiencing a health crisis, are they able to receive treatment in the community as opposed to ERs, emergency rooms, or jails? I represent a very large county, DeKalb County. My sheriff claims that she provides an enormous amount of health care, mental health services in the jail. What say you?
Yeah, no, I appreciate that, and those are good questions. So I will tell you that obviously different parts of the state have different levels of access just because of the rural nature. We're working hard to break those down. An example of that would be mobile crisis. That's available anywhere in Georgia. A lot of times we can get mobile crisis dispatched in a more rural area even quicker than we can the metro area, just because if you've tried to drive from here to DeKalb County, you know how difficult that is, and these folks don't run with blue lights and sirens. So mobile crisis available everywhere in the state. We're building out a network of crisis centers that will be in close proximity to everyone in the state of Georgia. On the issue of healthcare in jails, yes, that's just a factual statement. And I, sheriffs have a ministerial responsibility under the Constitution to provide health care services, and that expands to mental health care. So if someone has high blood pressure, they got to give them high blood pressure medicine. If someone's on a medication for mental illness, they got to provide that. Where we have to do better is in several fronts, and we're working on this. But one is when a court has ordered the person to come to the state for restoration, we got to get that wait time down so that within 30 days they're in a state hospital. The second thing we got to do is how do we prevent those folks from cycling back through the system? And I don't want to take up too much time, but I do think this is important. I will tell you that my mission is to figure out the individual, and I'm just going to give you an example, who has schizophrenia, who's medication non-compliant, who's been in jail 20 times, who's been in the hospital 10 times, ERs every month, who's been unhoused multiple times. Family has had to give up on them, basically. We know if that person's on the right medication, almost all the times they can function in community. How do we keep them on their medication? We just started a pilot program in Whitfield, Gordon, Henry, and we're going to have 2 other counties where the sheriffs have adopted some policies that we've drafted for them. Our forensic psychiatrist is acting as a consultant with their medical team. If they agree to put them on the medication, long-lasting injectables that we feel like we're recommending, we pay for it. And we're seeing great results from that. We're also going to assign that person a recovery monitor. So they're going to be almost on like mental health probation. So that person follows them into the community. And we're going to compare that to a control group. And we believe we're going to show significant progress. But we're heading to a place to resolve some of those challenges. The other thing I'll just mention, if you haven't heard from him, I suggest that this committee may consider Dr. Constantino's work at Children's Healthcare. Trauma-informed care, looking at, we know statistically when a child has this trauma, they're this much more likely to develop mental illness, this much more likely to be homeless, to be arrested, et cetera, or to go into foster care. If you can wrap services up on that child and that family then, and they're doing that, and they're using their endowment to offset what insurance and Medicaid doesn't pay, over the next decade, the results from that, I think, are going to change the landscape of how we treat individuals early in their life when things happen that we know statistically is going to create other problems.
I appreciate you mentioning the emergency departments. As an ER physician, I've seen that up close, and the sad part is that there's a slightly more expensive medicine that's long-acting injectable, as you mentioned, that could have prevented that relapse, kept that individual working, taking care of their kids, taking care of their family. I'm looking forward to hearing the results of that. I expect they'll be positive. Chairman Leverett.
Thank you, Mr. Chairman. Thank you for your testimony. Thank you for your service to Georgia too. I don't want to take too much time continuing to heap accolades on you, but I hope you understand the committee's feeling and our feeling as a legislature. 1 or 2 quick questions about your forensic services. When you use the term restoration, are you talking about restoring someone to competency so they can stand trial?
Correct. Yes, sir.
Okay. Does that also, I also sensed, so is the Jail Restoration Center for that provision of that service?
Yes, sir.
Okay. And then I think you also talked about providing service to folks who have been determined not guilty by reason of insanity. You basically, they stay with you. Does the term restoration refer to a process by which you try to, restore them to a more competent state as well?
Yeah. Great question. So if they're ordered to us for restoration, we have one mission, and that's to restore the person to competency, get them back to the court, let them go through the criminal justice process. If they're not guilty by reason of insanity, our mission is treatment. They're being ordered to us for treatment. And we give a regular annual report back to the court on those individuals. Or if something significantly changes, and we can say to the court, our doctor may say, we believe that, Mr. Hawkins is ready to be released, clinically ready to be released. The court may disagree, but yes, sir, those are the different populations.
And when they go back on a restoration in terms of competence to stand trial, I guess they go back and then is there a hearing where your staff would testify while they feel he's ready to stand trial, or how does that happen?
That's right. So the court's notified that the person's ready. They have to have a hearing. The law requires they have a hearing in a certain period of time. If the court determines yes, they are, then they will set it for motions, or they'll set it for trial or plea, whatever it may be. We also send a treatment plan with the person when they're released so that the jail and others know what kind of medication they're on. And then once they go into the Department of Corrections, if they go there, then the Department of Corrections is responsible for treating the individual.
And so I guess to that point you just mentioned, if you make that finding in the pretrial context where there's an incompetency determination, incompetency to stand trial, if you send them back, you then they have the hearing, and then that person would then leave your custody and go back to the jail, but you provide support in the form of a treatment plan that the jail would follow. while they're awaiting, while they're.
That's right. Now, I can't say in every case that, every jail is different. So what they do and decide to do is different. Sometimes we do get people who then linger long enough, they go back incompetent, and we get those individuals
Come back
back.
to.
So we're trying in all of those different aspects, how can we reduce those numbers also so that the individuals don't linger?
Thank you very
Yes.
much. Thank you, Mr. Chairman.
Appreciate it. You sound like you might have had some years in law enforcement. How many was it?
Yeah, I was 18 years. I ran a law enforcement agency for 11 years. And that, to be quite
Some
frankly,
people are
that's
uniquely
one of the-
qualified for their role in government.
Yeah, and I was very frustrated with the system. So we will try to make it better.
Thank you, Chairman Taylor. Did you go ahead?
Yes, thank you, Mr. Chairman. Again, I would say over the last 4 or 5 years, when this really has come to the surface, the achievements you've made are very, very impressive. And it does reach the whole state. There's always going to be places that we can go. But one of the things, after hearing so many things, what is the largest thing that we can do as the legislature now? Where do we need to put our support? Is there one area you feel like we need to focus more on? I know money, but is there some big major project, something you want to tell us about?
He's probably watching, so I'll just say the OPP director always tries to pin me down with this too. And it is challenging because the whole system has to come up together, because if you just fund or put resources in one area, then it's just going to create a bottleneck somewhere else. So we're trying to be very intentional about how we bring the whole system up, and that's why it takes a little bit of time and it can become frustrating. I will say, though, that keeping updated with the rates for Medicaid reimbursement is extremely important, because we have to have an adequate workforce. And if we're not able to pay individuals a livable wage, it's going to have a downstream effect on the entire system. Because if I can't get folks adequate provider network to serve our population in community, it's very challenging. So I would think that, and that's why we put the language in the legislation about every 4 years, because if not, you wake up 20 years from now and you got a $157 million hole like we did the last time, and that becomes almost overwhelming.
Thank you. Brief, yes, please.
Thank you. I agree with you. This is something we've talked about throughout our medical needs in the state. I have a saying that I'll share with you. You've built quite a array in helping these people. If you build it, they will come. But if you don't pay them, they ain't staying.
Yeah, that's right. That's right. Amen.
Representative Buckner.
Mine, as a follow-up, I want to say thank you. You're doing great work, and you've always been great at organizing, and appreciate that. When we talked about the rate studies and we're looking at how we can encourage psychiatry and that kind of thing, my question is, what about the other support staff? Is that included in those rate studies? And is that included in how we're looking to provide the training needed for them?
Yeah. So if it is a provider, Medicaid provider, then yes, all of those different services are considered in rate studies. From our perspective, one of the things, and I'll give you a real quick example, like on the developmental disability population, one of our challenges has been getting direct care professionals to work in the space. That's kind of the entry level. So we worked with Dr. Laws at the University of Georgia, who's a national expert in this area, to create a training program, certification program for different levels for the direct care support. And we received some funding during COVID to be able to increase those staff salaries based on that. That's something we ultimately want to get put in permanently. So there are some opportunities to do some things like that. But yes, if it's a Medicaid provider, the rate study will look at everything.
Okay, thank you.
Thank you. And our last question, Representative Seabaugh.
Thank you, Mr. Chairman, and ditto on all the accolades you.
Thank you.
And we really appreciate what you've done. Talk a little bit about the co-responder thing.
Hit your button again, please, sir. Go ahead, sir.
Good. I want to talk about the co-responder program. Are law enforcement agencies, are they eager to participate in the co-responder program?
Yes, obviously, every law enforcement agency is different. They have different thoughts about things, but we're getting more and more agencies that are coming on board. There's a video, we're happy to send it to you, where Donnie Craig, the sheriff in Pickens County, talks about his experience, where he's been in law enforcement 35 plus years, totally against the idea of co-responder. But now that he has it, he's tearing up as he's telling the story. He said, we couldn't live without it. The other thing I'll just mention around that, we also revamped the crisis intervention training, CIT. We have 2 full-time staff members that work in our police side that provide that training all around the state. They're in Forsyth County this week. That's a 1-week training that brings law enforcement. It gives 40 hours of post credit to law enforcement. That's really a game changer too. But yes, the co-responder program has been extremely successful to the point that it results in almost 0 arrests. So when a co-responder team goes, rarely is an arrest ever made.
I'm a big fan of the co-responder program. I was involved with that years ago when they were beta testing that. But you're absolutely right. It does result in a lot of people not getting arrested, but getting the treatment and help that they need for that.
Yes, sir.
And one other question, if I may,
Sure.
the forensic beds, how many more beds do you need to make that complete?
So you funded 40 additional jail-based restoration beds in Augusta. Those are about to be under construction. They'll be open next October, and the new 300-bed hospital. I'm hopeful that with all of those additions, and with us continuing to reduce, hopefully the time it takes us to restore, because we're learning every day how to do it better, that we'll have a sufficient number, but we'll see.
Okay. Thank
Yes,
Right. Thank you to you and your department. Appreciate the thoughtful questions from the committee as well. And we look forward to, as we go through these meetings over the next several months, if there's some follow-up questions or something. But thank you for that thorough presentation, sir.
Anything we can do. Thank you.
Thank you. We're going to go on now to the Department of Community Health. And if Sylvan, Brandy, if you can come on up and introduce yourself. And certainly this is community health is in our title of our Blue Ribbon Committee. And we know that involves a lot of government services, but also rules and regulations for so many others. Appreciate y'all's work on it. Even though we're a little behind, we will give you certainly full time you need and full time for the committee to ask questions. We'll cut our lunch break a little short if we have to. No. We'll bring some biscuits or something. Come on up and just, I think we have those microphones, I believe, are both working. If you can introduce yourself to those and those watching. Thank you for being here today.
Good morning, Mr. Chairman, members of the committee. Appreciate y'all having us here this morning. My name is, sorry about that. My name is Brandy Sylvan. I am the Director of Government Relations for the Department of Community Health. I have Emily Yona, our Chief of Staff, here with me, and a few other folks if y'all want to dive too deeply into questions that can help us get you the information you're looking for. We were asked to come today to just provide an overview of the department and what we do, as well as an update on legislation that has passed since 2018, which the department needed to implement. All right, we can move forward. All right, so an overview of the agency. We are led by your former colleague, Dr. Dean Burke is our commissioner. We have a staff of about 650 based in Atlanta and Cordele. And then we have nurse surveyors that work throughout the state. Our annual budget for state fiscal year 27 is $25.7 billion. Our major programs include Medicaid, Peach Care for Kids, and the State Health Benefit Plan. And our offices include Healthcare Facility Regulation, the Office of Health Planning, and the State Office of Rural Health. We also had provide administrative functions for 3 attached agencies, and you'll be hearing from all of those folks later as well. Next is our budget. This is the FY27 budget, just so you can see a breakdown of how our funds are expended. The main thing I just want to point out is if you'll notice about over 90% of our budget goes directly into benefits payment. So it is a pretty significant budget, but it is all it is largely directly sent into benefits. Now I'll give a high-level overview of those major offices and programs that I highlighted on the first slide. The Medical Assistance Plans Division administers our Georgia Medicaid, Peach Care for Kids, and the Georgia Pathways to Coverage programs. Through these programs, we provide healthcare coverage to over 2 million Georgians. We also have within that MAP division, the Katie Beckett Medicaid program and home and community-based services. So those major waivers include the elderly and disabled, commonly known as CCSP and SOURCE, and the independent care waiver and the now comp waivers. And as Commissioner Tanner mentioned, DBHTD administers that one. Next, we'll look at the State Health Benefit Plan. So this is the health insurance plan for state employees, public school employees, the retirees of those systems, and their dependents. Current enrollment is over 665,000 lives. That includes members and their dependents. In FY26, the plan spent about $5.1 billion, just to give you a sense of how large of a plan we have. The Healthcare Facility Regulation Division protects the health and safety of Georgians through the licensing of healthcare facilities. They issue initial licenses, conduct regular inspections, and conduct investigations based on complaints received from the public. Currently, they have oversight of about 32,000 healthcare facilities in the state. And we work not only at providing oversight of state licensed facilities, but also on behalf of the Federal Centers for Medicare and Medicaid Services to do the oversight of federal facilities. Next is the Office of Health Planning, which administers our Certificate of Need program in the state. So they review applications and requests for exceptions. They also collect data, including the annual hospital financial survey, which is a very informative kind of insight and snapshot into the healthcare throughout the state. Next, we have the State Office of Rural Health. Every state has a designated office. This is based in Cordele, Georgia. Their role is to improve access to healthcare in rural parts of the state. And this is largely through the administration of both federal and state grants. So in FY26, they had administered over $27 million. I did want to highlight one of the grants that comes out of this office is appropriated by the legislature each year. Excuse me. That's the Rural Hospital Stabilization Program. And that was begun in 2014. Since that program was initiated, 85 grants have been executed to 39 different hospitals, totaling $53.5 million. So thank you for that. All right, in this section, I'm going to go over legislation that has passed since 2018. This will be a very high-level overview. I have organized them in the presentation based on categories and then chronologically within those categories. I do want to reiterate, this is certainly not a comprehensive list. We gave you all a packet with our bill summaries from all of those years. So that has a lot more information on all of the legislation we have looked at. So if there's something I don't cover today or that you would like more information on, please feel free to follow up on that. Oh, and I would also like to clarify, this does not include any highlights of items included in the budget. This is just legislation.
Which we could do separately for you guys. That just wasn't the intent of today, but glad to do that if needed.
All right, the first category is Medicaid eligibility and enrollment. Senate Bill 406 in 2018 was a criminal justice reform bill. One of the items in this legislation allowed us to make eligibility determinations for Medicaid for an inmate in a county or a state prison who would be either released or getting out of parole, so that at the time of their release, they could have services in place and have that access to health care immediately. Because we were hearing a lot about individuals that got out and didn't have help, couldn't continue their mental health medications. Senate Bill 106 in 2019, this was the Patients First Act. This authorized DCH to submit an 1115 waiver to CMS to provide Medicaid coverage for individuals up to 100% of the federal poverty level. We did submit that, and that became the Georgia Pathways to Coverage program. The bill also authorized submission of a 1332 waiver, which is now the Georgia Access Program, and the Insurance Commissioner's Office administers that program, and I believe they'll go into more detail on that. House Bill 1114 in 2020 extended postpartum Medicaid coverage out to 6 months. You'll see in 2022, though, Senate Bill 338 extended that out to 1 year. So now a pregnancy Medicaid, they maintain that coverage for a year after delivery. House Bill 163 in 2021 directed us to implement express lane enrollment. This is an automatic enrollment and renewal system for children based on application data received from SNAP applications. And then finally, Senate Bill 428 in 2026 directed DCH to apply for a 1950C Medicaid waiver for adults in need of mental health services that don't meet an institutional level of care. We are working on getting everything ready to prepare that application. All right, the next one is healthcare financing. Many of the bills that would fall under this umbrella are related to either the rural hospital tax credit or the assessment of provider fees, which are used to draw down federal matching funds. House Bill 321 in 2019 established financial transparency requirements for nonprofit hospitals, and they have to share that information on their website. If we look down a little bit ahead to SB 505 in 2024, that legislation built on the previous requirement and directed DCH to create a template for these hospitals so that it was standardized and they all look the same. We currently, all but 2 hospitals are fully in compliance, and we are working with those 2 to make sure they have current and accurate information on their website. All right, we'll move on to the next slide, health plan coverage and patient protections. A lot of the bills in here apply to both to all commercial insurance plans. They're not necessarily specific to state health benefit plan or Medicaid. So I'm not going to dive too deeply into all of these, but did want to highlight a few. House Bill 888 in 2020 was a very significant bill related to surprise billing, intended to protect patients from receiving a bill if they had received services from an out-of-network provider in an emergency situation. And then a bill that built off of that, down near the bottom, House Bill 506 in 2026 added ground ambulance to that legislation as well. House Bill 85 in 2023 required health plans to provide coverage for biomarker testing. We are providing that coverage already. Senate Bill 106 in 2023 required DCH to provide remote maternal health clinical services for 2 years to Medicaid members that met certain criteria, and we executed that program in partnership with the Department of Public Health. House Bill 422 in 2025 allowed state employees enrolled in a high deductible health plan under the state health benefit plan to make pre-tax contributions to a health savings account. And then House Bill 1118 passed this last year and will require insurers to cover a 12-month supply of contraceptives. The next topic is pharmacy benefits administration. This has certainly been an area of interest as long as I've been with the department. So House Bill 233 was passed in 2019. This was an anti-steering bill intended to ensure that PBMs could not require you to use their affiliate pharmacies. In 2020, we had House Bill 946 and Senate Bill 313. These were identical pieces of legislation that required PBMs to charge the intent was to eliminate what we call spread pricing. The PBM could not charge the plan more than they're paying the pharmacy for a given drug. And that is required to be reported annually.
Just for a quick clarification on this health plan coverage, patient protections, the list we did, some great things along with these pharmacy benefit administration sometimes. Now, these, obviously there's going to be overlap with the Department of Insurance. And so, and there's also the problem of federal preemption and the fact that a federally regulated insurance plan, as I mentioned, over 62% of Georgians are covered by, their families are covered by a plan that really isn't, we can influence it a little bit and we can touch on it at times, but, and Medicare and Medicaid rules are all set federally. So really there's so many individuals when we try to move the needle on coverage arrangements or PBM arrangements or trying to lower prescription prices, we're always having one or one and a half hands tied behind our back, correct? Because federal preemption of all those employer sponsored and paid plans are exempt from Georgia requirements. Is that right?
This is a little outside my lane, but yes, sir.
Okay, maybe we'll hear
So,
more when we hear
the
from the
plans.
Department of Insurance a little bit to find out, because I do believe there's ways our rules influence, especially if a provider, an insurance provider, has both state regulated and federally regulated only.
I think one distinction there is for what we manage as far as DCH is the state health benefit plan, it's fully self-insured. And so we have the ability to control the state health benefit plan, which as you guys have seen, oftentimes that's why there's a lot of legislation that looks at the state health benefit plan because we actually fully control that plan within reason, right?
Because insurers don't participate in those 665,000 covered lives.
Exactly.
Right.
So again, Brandy's correct. We would defer to the Department of Insurance regarding the other plans, but as far as the state health benefit plan, we have control of that and that includes the teachers and then state employees. So USG has their own plan as well, but just for clarification.
Thank you.
And then also sometimes those bills do direct Medicaid coverage of certain things as well. It depends on how the legislation's written and which code sections are included, but those bills get messy quickly. But yes, in general, those cannot be applied to any of our plans.
I think the big thing, I feel like I have to say this just with everything and really the challenge for us usually with state health benefit plan or Medicaid to add things is a budget item. Because as y'all know, we can create a bill and do that, but if it is not funded, at least since we've been at the department, then that can't exist because I think, there is additional costs on the state health benefit plan and Medicaid when you increase codes or what that is. And so if there is a barrier to those, it's usually related to budget. We just have to say that. So.
Thank you.
No problem. So back on the Pharmacy Benefits Administration, the last one I wanted to highlight is the last bill on this list, House Bill 196, passed in 2025, which required SHBP to reimburse pharmacies at the NADAC, the National Average Drug Acquisition Cost, and set a dispensing fee that would be administered with that NADAC pricing of $10.50 for chain pharmacies and $11.50 for independent pharmacies. Next category is behavioral and mental health. Commissioner Tanner talked a little bit about House Bill 1013, which was passed in 2022. This was definitely a significant comprehensive piece of legislation. The items in the legislation that impacted DCH are related to requiring that we are in compliance with federal mental health parity requirements. And we established a complaint portal for any suspected violations of those parity requirements. And we do submit an annual report on what is received through that portal each year. The bill also established a minimum 85% medical loss ratio for our Medicaid care management organization contracts, and it created what's known as match teams, multi-agency treatment for children. So this is for children with complex needs. It directs the departments to work together to coordinate those services and make sure we're accessing all the resources that might be beneficial. In 2025, House Bill 584 passed. So in our licensing division, DCH previously oversaw the licensing of drug abuse treatment and education programs, narcotic treatment programs, community living arrangements, and adult residential mental health facilities. That bill transitioned the oversight of those programs from DCH to DBHDD, since they are more aligned with the subject matter expertise for those facilities. And that transition is complete, and as far as I've heard, has gone fairly well. Next category is long-term care. Senate Bill 406 in 2018. This was the Georgia Long-Term Care Background Check Program. This authorized to require facilities to conduct registry searches and fingerprint-based background checks for employees in long-term care facilities that would have direct patient access. It also created a caregiver registry, which allows an individual that wishes to privately hire a caregiver to request a background search through DCH for that hiring as well. House Bill 91 in 2019 authorized the RATBAC program for that, background check program, so that any individual who had those fingerprints, their fingerprints could be retained for a continuous monitoring and real-time alert of an arrest. House Bill 987 in 2020. This was a very significant comprehensive bill related to requirements to be a long-term care facility. A lot of the focus of this legislation was on minimum staffing requirements, staffing training, what is needed to submit that demonstration of financial stability. It also created a new certification for memory care centers. That certification did not previously exist. And so we said, if you want to provide those services, you kind of have to have a little bit stepped up requirements, and it established all of those. Moving down, House Bill 663 in 2024. This was in response to some of the visitation restrictions during the public health emergency, and it prohibited hospitals and long-term care facilities, with limited defined exceptions in the bill, from restricting patient access to a designated essential caregiver. House Bill 1078 in 2024 established the Georgia PACE program. This is a capitated payment program for individuals that are dually eligible for both Medicare and Medicaid. And we have executed 3 awards already for that program, and there are 2 more pending. So we're excited to see how our members are doing once those programs are up and running. Next category is certificate of need. There have been a few kind of one-off bills, but I just put on here the 2 kind of comprehensive bills that have passed within that time frame. In 2019, House Bill 186 passed, which changed some of the CON requirements. It created a general cancer hospital destination. It was previously a destination cancer hospital. It raised the capital expenditure limits and put some parameters around who could oppose a CON application. That bill also created the Governor's Office of Health Strategy and Coordination. And then in 2024, House Bill 1339 made some additional revisions and updates. It provided additional exemptions, modified the application process, as well as the appeals process, and directed DCH to review and update the state plan every 5 years. So we are doing a staggered review of the healthcare needs in the state through the creation of several technical advisory committees. They provide recommendations to DCH that we will then be reviewing for consideration of any rule changes that might help improve that system. So that is the end of my formal presentation, and we'll be happy to answer any questions you guys may have.
Appreciate you leaving out 100 other bills that we passed that affect the department at least.
I have them though.
I did have a quick questions, and we'll get to the committee if there are any. You mentioned one thing about the House Bill 163, and some of this we can follow up with in a later meeting if we need to. The express lane coverage of children, which is great to expedite it when there's similar requirements for participation in a federal plan. But we did understand this past year that there were some challenges with HR 1 and making sure that both our SNAP benefits and our Medicaid eligibility, which correct me if I'm wrong, is that done by DCH or is it done by DHS or?
So for our low-income Medicaid programs, the Department of Human Services DFACS division does those eligibility determinations.
So sometimes we may need to update if we have an express lane that doesn't allow or doesn't allow for the fact that there are penalties associated with not meeting the federal requirements. And the feds do pay about 2/3 of these programs. So certainly those roles are in there. I would like to see if we have a plan for how to address that. One other bill you mentioned, I think it was House Bill 506 about EMS being under surprise billing. I am kind of curious. We have EMS as one of our topics we want to discuss at our next meeting, which will, by the way, will be in Augusta, but we are going to have some a focus on EMS for about half of that meeting. And I would like to hear a little bit more about where that is with EMS and how the surprise billing payment. I know for the federal government kind of usurped some of the pioneering changes we made first, and then the feds finally did come along and address surprise billing with dispute resolution and things like that. I would like to hear if that's also included under EMS, if that's okay with you guys.
And I will say during our assessment of that legislation, we did not see a significant anticipated impact to the state health benefit plan. So, that may be another, it may be that the insurance commissioner's office also has more information they can share from the other commercial plans throughout the state.
Thank you. Let me get to appreciate your efficiency there with a large request from us. Representative Seabaugh. No, let me try it again. Hit it one more time. Yes, sir. Lord Leader.
Thank you. Thank you, ladies, for your presentation. In 2020, we extended the postpartum Medicaid coverage to 6 months, and then I think 2022 to a year. Have we seen the death rates or the problem rates of those? Do we have some good data showing that has made a significant difference with our postpartum problems that we were having?
Yeah, I mean, we work directly with the Department of Public Health on that. And I think probably they would refer to that, but we can get you some more data. We can get you some data on the Medicaid side specifically, but we do work just with the Department of Public Health on that. And I know they measure that as well. So together we should be able to provide that.
Okay, good. And then on the ambulance, the non-governmental ambulance UPL payments, have we stabilized the timing of those payments? Or are we working toward getting that done?
We are doing our best on stabilizing UPL payments, and that's really any kind of federal supplemental payments. The challenge we have is they get approved by CMS at a different rate. So we send those up on a pretty consistent basis, but then CMS has to approve those and then they come back. So that's our challenge right there. We are always, though I can say from the commissioner, myself, all of us, Joe included in the back, who could also answer anything more if there's anything to add, but we're always trying to get to a timeline to provide you guys, but it's really the challenges with, we don't know when we're going to get that federal approval back, because as you talked about, a lot of that is federal money.
We don't have that problem with the governmental payments, just the private payments. So I'd really like for us to work to figure that out, because the feds are blaming us, we're blaming the feds, and there's something not connecting there. It's been 6 years. We ought to be able to figure that out. So we're very interested in seeing what our plan is to get that done sooner than later.
Yep.
Thank you. Thank you, Mr. Chairman.
Thank you. Thank you, Representative Buckner.
Thank you, Mr. Chairman. Great presentation. Lots of good information. My first question, if I have time for two, I will do this one. This is most important to me. The Pathways program. I'm just curious if it's keeping pace in Georgia with the number of uninsured lives. What are the numbers compared to, what's happening out there as far as people enrolling and using the program versus the need that's out there of people that are not insured?
Yeah, I think, that's an interesting question. I think, we've seen Pathways, we've seen the first iteration of Pathways, and I can tell you we're there's about or over 18,000 current members on Pathways and about 33,000 overall is kind of how we measure that. So today, the Pathways program was intended for a specific population of working adults up to 100% of the federal poverty level. We've seen great, tremendous improvement in that. I mean, we had a lot of challenges at first with lawsuits and also just getting our systems ready. I think what's going to be interesting, and it's the reality here, we actually took to our board, this last board meeting, is with the introduction passage of HR 1 and the community engagement requirements, we're going to see the Pathways program transition to kind of a new program in 1/1/27. And we can spend some more time on that if you'd like at a meeting, because there's a lot of details there. But again, we took it back to our board meeting in July for initial adoption. We'll take it in final in August is the plan. But two big changes that I think need to be talked about is we currently allow parents and legal guardians up to 6, but in starting 1/1/27, it'll be caregivers up to the age of 14, and we're still working with the federal government to define that, and that's in some of our rules, and then also of medically frail is the other population. So they don't quite meet the SSI determination of disabled, but they meet a determination of unable to work. And so right now, that's an entirely new population for Pathways. And again, we can get you more information. Glad to get our public notice that's posted right now on our website has a wealth of information, as well as our Medicaid director did probably one of our longer presentations to our board, and we can get you that recording and kind of talk more about that, because I think that's where we really talk about Pathways and where it's going. And we're doing a lot of work as a department to kind of get ready for that, along with our other partners, including, just want to give credit to DBHCD, DHS, and then DPH, because they've helped contribute to kind of research that for us and help with us. So, we're glad to get that information to you.
Mr. Chairman, if I may, is quick. Okay. Yeah. It was mentioned in the mental health program for community-based services and through the waiver program that there's a rate study that's supposed to be done every 4 years. Where are we in the sequence for that? Is it time for it to come up and be done?
Yes, we are. So the first step of that is actually, and again, this is unfortunately, it's a funding thing. So we together with DHD and DSH will come to you with a request. And I believe we're talking about doing this next legislative session in partnership with them, because we need the money to do the study. And then the rate, and then you guys can decide to increase the rates based on that. But we're up for that time frame. And so together with DBHD, you should see a request from us come this next legislative session to do that, barring what happens with the budget. So
certainly the budget does affect things. I know you mentioned Pathways program. Of course, in the name of that is the goal that someone, maybe if they need to get on their medication, their long-term medication, I think we talked about for mental illness and all, if we can help with that when they're below the poverty level, below 100% of the poverty level, which is actually pretty low, is one of the goals of the Pathway program, from what I recall in its passage, is that people will quickly get above the poverty level with their employment. And if they have health coverage, then maybe they're going to stay healthy enough to keep a job. And at that point, above 100, they get a federally funded program, an ACA plan that might be an Anthem plan, just with the same network State Health Benefits has, and would no longer even be needing, would no longer be needing that 1/3 state match. So I know that's one of the goals of the Pathway program, really, is for people to work themselves off it as they get health care below the poverty level. They get above the poverty level, keep a job, and they go on a federally funded ACA plan, certainly up to about 200% of the poverty level. So I think that's it's great that it's in the name, that it's a pathway to get off Medicaid and not to stay on it. Chairman Taylor.
Thank you, Mr. Chairman. Thank you to the department and the things that you do. the department is so large and has such a diverse scope of what you have to have oversight on. Is there one area that you see is more troublesome or hard to work with? And are you able to coordinate with the Office of Health Strategy and coordination with the governor's office? How does that fit into your piece? How do we get the direction? And what are the bullet points that you go to first?
Yeah, I mean, we work all the time with the governor's office and the health strategy and coordination and what's left of that. I mean, that's really, with OPB, with the governor's office and, health strategy and coordination and the people there. I think it's not, and just to be honest, we do, as you stated, a wealth of different, subject matters and divisions, and we seem to grow. And for us, we're always willing to do that. And I think they have the capability. It's just the resources that we need. We have a very lean staff. And that do have many jobs and many hats. And so I don't know that there's one area that, and I should mention, there's been a lot of federal pressure, as there always is, but recently there's been a lot of federal pressures coming down, which, as you said perfectly, Chair Newton, a lot of our funding comes from federal government. So, we weigh that every day. I think for us, it's just always trying to find more people. Talent is always a challenge. But again, I think there's not one area that I would say we have troubles with. It's just always having the resources to make sure that we can deliver for the legislature, the state of Georgia, and really the members that we serve.
It's such a large package. It's hard to tie it all together, even looking at the high view that we look at it. But thank you for all your efforts and what you do. Thank you.
And speaking of the governor's office, Governor Floor Leader Seabaugh.
Thank you. Just wanted to comment on the PACE program. I believe you said that you have 3 providers and they're going to be coming online soon. They're not up and running right now.
Right. We've issued awards for 3 of the 5.
Good.
So they'll begin building those now.
That's
Good.
to give them basically the permission to start building. So, and I know that one in particular is getting close. Savannah, my understanding, is the furthest along, and we can state that, but they're all kind of in that process.
Okay. I think that's going to be a exceptional program for our senior population. I think it's going to keep them healthier.
Yes,
I
sir.
think it's going to keep them out of the crowded hospitals and those kind of things. So I look forward to seeing some results on that in the next couple of years. I think that's going to save the state a lot of money and keep our seniors healthy. So good
Yes,
job
sir.
on getting
Very excited about it.
that moving. Thank you.
Health Chairman Hawkins. Yes, sir.
Thank you. Do we have any updates on the situation with the 20% cuts, to the behavioral health segment, the providers since we last met?
From a DCH perspective, again, I think, I know you had a great hearing and we talked about this a lot. And I think,
That was a
just,
CMO that cut. Is that right?
Yeah.
One or
There-
more CMOs?
Yeah,
And-
two of them.
2 CMOs. Okay.
it's been some rate cuts and as again, from where DCH sits, again, we don't just, and I know you know this, but just have to state it for the record. DCH does not control the rates between the providers and the CMOs. That what we do have control over, though, is the contract that we have with the CMOs. And a big portion of that is network adequacy. Our duty is to the member to make sure they are getting the services that they receive. And we are continuously monitoring that. And I can tell you, we're required, we were going from quarterly now to monthly, and we're actually, the commissioners asked to do it weekly. So we're reviewing that on a constant basis and we can provide that information, but it is just on our minds as much as it is on y'all's. And we will continue to be diligent about that. And if and when the network adequacy falls below levels, we will take the corrective actions that we need to, and we feel confident about that.
There's really no assessment of the number of lost providers.
We do have, again, we're checking our roles and making sure, and right now there have not been again enough that we've seen to fit. And we measure network adequacy, just to be very clear, where it was, right? Because the reality is there are going to be counties that we know that just don't have providers. And so we have to do this in a very targeted way, just to be very clear. But as of today, and like I said, we're checking weekly, it has not dropped to a level that we are yet taking corrective action, but we are again checking weekly.
These providers, if they reduce their Medicaid patient load, can you pick that up also? In other words, you may have
They limit it.
limited. Is there any way in your metrics you can see that?
Again, ours is to make sure the member gets served. So we're checking to make sure that that member has a provider. And if they don't, then I think, and again, Lynette Rhodes came, our Chief Health Policy Officer, and talked about this, and we can provide details and our Medicaid director Stewart's in the back. So if he needs to jump in, he can as well. But it's really on making sure for us, making sure that member has services and we're reviewing and there are criteria that if a CMO is going to drop a member or excuse me, a provider, does the members that go to them have plans in place? And we are checking that. And currently we can see that they are planning for those members.
The thing I'm referring to is that there's been ongoing for the last 20 years, geo access models that they look at. You know, you may show that you got 20 providers in a certain area and geo access looks good, but half of those have now went to 1 day a week rather than 3 or 4 days a week. So that's what I'm just wondering if you can see a pickup on that.
Let us take that back and we
Yeah,
can review
okay.
and we can see what we can get from, I know again, we've been really, this has been on all of our minds. And so we're constantly trying to improve that process and add to it. So I'll see if that's something we can get for you and review.
Just to follow up on that, we did hear from Commissioner Tanner as well as y'all about rate studies. And it's a little interesting when you do rate studies, but then when it's given to CMOs, they don't necessarily have to follow the rates unless that was in the contract or something. So it's kind of interesting, this balance between we want to do rate studies to make sure we're paying enough to get the workforce that we need. But then if somebody, for lack of a better term, a contractor or middleman lowers those rates, it kind of questions the role of a rate study if no one's required to pay that rate. Maybe that's something you can, if you have some follow-up information to help us understand a little better. But
And I would like to clarify specifically to the Senate Bill 610 rate studies that those are for our waiver programs, which would not be in the managed care system.
okay.
But in general, I definitely hear what you're saying that
Thank you very much for your presentation, for your commissioner. We appreciate his long service as a senator and now as a doctor and a senator and a commissioner. But thank you for y'all's very competent presentation, very thorough. Thank you.
Thank y'all.
We're going to go now. We're going to hear from the Department of Public Health. Ms. Andrews, if you can come on up, Megan. Good morning. It is still morning. And we do have some yes, all our members did get our handouts. So if you want to start us off,
Yeah.
appreciate it if you could introduce yourself to those watching or participating.
Absolutely. Is this on? Okay, perfect. Hi, everyone. I'm Megan Andrews. I'm the Assistant Commissioner for Policy at the Georgia Department of Public Health. I have Graham Segrest with me, my Director of Government Affairs. So I will run through a quick introduction of public health. We cover a very broad array of topics, but I'm going to focus on the county boards of health and services, direct services available locally. So Graham, you can skip actually 2 slides. So this is a map that is shown every budget hearing. So you may have seen it at some point. This is how we have the state divided up into public health districts, and it's how we manage our system. So there's one state office, which is over at Twin Towers, 18 public health districts, as you can see here. And then there's 159 independent county boards of health. They are established in statute and appointed locally at the county level. That also help manage the local services available at county health departments. You can go to the next slide. So each of our districts, there's 18 of them, is managed by a district health director, and they serve as the CEO of the boards of health and the health departments within their district. That individual is appointed by the Commissioner of Public Health, but does need to be approved by the local county boards of health. So in some of our larger districts that have 13 counties, the 13 county boards of health have to come together and vote to approve the hiring of that individual. So they call this a hybrid system, a hybrid governance system where there's both state and local control, and we have to work together in order to get anything done. You can go to the next slide. So at the state level, we provide general oversight and direction to the county boards of health and the districts. We provide technical assistance. We receive funds and then allocate it out to the district. And we oversee the programmatic operations. The districts serve as the administrative hub between the state and the local health departments. So there's central services that are within the district, like HR, IT, a district nurse, a district environmental health director, and they serve as the management and kind of liaisons. So when the state comes up with something and we send it down, the district is the one that manages, then all of the counties that are underneath them to get it done. The counties are the ones that provide the direct services. So when you drive down the road in your district and you see a health department, that's run by the county board of health. And primarily is funded by the state office with some local contribution from the county. And those county health departments provide direct services to the constituents and in your district, including things like STD screening and treatment, HIV screening, vaccinations, vital records, restaurant and septic inspections, things of that nature. You can go to the next slide. So there are some core services that are available at all health departments. Some of the larger health departments that have additional funding, they provide additional services above and beyond these minimum services that are available, things like travel, vaccine clinics, things like that. So I'm not going to read all of them, but these are all the services that you can get in any health department, even the smallest one. I will say the access may be different. There are some counties that has a nurse that is shared between counties. So there may not be clinic hours 5 days a week. It may be 2 days a week and she's in another county the other 3 days. But there is access to these services everywhere. You can go to the next slide. And then since we have House budget here, this is how these programs are funded. Our office is primarily federally funded. We're about 50%, a little over 50% of federal funds, and then state funds help supplement that. So you can see categorized here how our programs are funded. Some have various fund sources. Local funds are the county contribution or fees collected that are retained locally, then go back into the programmatic operation. So I'll run through a few of these examples of the services we provide just to give you a high level perspective. So we have vaccinations, family planning services, which also includes pregnancy tests, STD services for testing and treatment, HIV services, tuberculosis, and then WIC is our nutrition program for women, infant, and children, and that's available through county health departments, and it's funded by USDA. Children First, Babies Can't Wait, and Children's Medical Services all provide early intervention services for children with developmental delays. We also do ear, eye, and dental screenings for children for school admission. We have breast and cervical cancer screenings available through our family planning clinic. And then environmental health services, which covers hotels, pools, restaurants, septic tanks, a wide array of topics. Next slide. So I know you wanted an overview of direct impact legislation that has passed. You have a list in your folders of all of the direct impact bills that have passed since I've been at DPH, which is 2019. And here's a just graph for you over the years. These are all of the track direct impact bills, and then the gray scaled ones are the ones that have passed. So you can see year over year, we have about 30 bills that you all passed that then over the summer and the fall, we have to go back and implement. It could be a simple education, update a form. It could be more complex. When I go through the legislation that passed, I'm going to do something that all the bills that were a little more intensive, just because I think it's a better use of our time. So you can go to the next slide. So in the 2019 to 2020 session, there's 3 bills I'm going to cover. House Bill 217 had DPH begin syringe services programs. We had to adopt regulations and oversee the permitting of these facilities. It also created a PrEP pilot program that was funded by you all, where PrEP services are provided in health departments. This is a medication individuals can take to prevent themselves from contracting HIV. It's actually a really amazing medical advancement that's available in HIV care. And then body art. We began inspecting and regulating body art studios, so piercings, tattoos. That also falls under environmental health. So when I say a broad array, I mean it. Next slide. So in 2021 through 2022, the first bill I'm going to talk about is House Bill 567. It established the Newborn Screening Advisory Committee into statute. And this is the committee of experts that looks at conditions to add to the newborn screening panel. And I'm actually going to go into more depth on that at the end of the presentation. House Bill 918 established the Georgia Rare Disease Advisory Council. That's a new council that sits under DPH, and we provide administrative support to them. House Bill 1443 was the statewide food truck permits that created some significant changes that needed to happen across our system. Like I said, the counties are the ones that manage the day-to-day services. So we need to get everyone all on the same page on how we issue a permit that can cross county lines. So we have done and implemented that legislation as well. Senate Bill 106 was the Healthy Babies Act. It had DPH create a rural maternal home visiting pilot program, and it was funded that same year. I'm going to go into that in a lot more detail as well at the end of the presentation. It is one of the keynote programs of our commissioner. She's very passionate about it, and it has really done some amazing work. I'm going to play a video for you too about the program, and so you can hear directly from families that have been impacted. The next one is Senate Bill 107, which was required DPH to develop a model aquatic safety plan. This is for swim lessons and minimum standards for swim instructors to have in order to prevent drowning. Next slide. So this is the most recent legislative sessions. House Bill 89 was actually our DPH agency legislation that codified the regional perinatal centers and the process to strengthen our perinatal system. So we have hospital hubs throughout the state where there sits expertise in perinatal care. So it's a hub and spoke model. If there's the providers out in the communities know to refer into these centers, and they serve as the experts in maternal care, especially in high-risk situations. The next two are actually from this most recent legislative session, so we're in the process of implementation now. First is House Bill 1138, which is increasing access to contraceptives and allowing pharmacists to dispense it. So DPH is to establish a statewide protocol in partnership with the Board of Pharmacy, and we have our experts meeting together to work on those protocols currently. And then Senate Bill 220 created some significant changes to what was formerly called the low THC oil program. It's now referred to as the medical cannabis program. As far as updates to conditions, parameters on who can certify patients, the name of the program. So we've been in the process of implementing all of those updates, and there will be more to come over the coming months. And I'll also go into that program into greater detail. Graham, you can stay on this slide. So there's three things I know you all wanted to hear about upcoming issues, and three of these bills that passed, there's been some changes going on that I want to make sure you all are aware about, because you are very likely to hear about it in the next session. So the first one is from 2021 House Bill 567, which was the newborn screening program. So this House Bill 567 from 2021. It established the Newborn Screening Advisory Committee. So in Georgia, every baby gets a heel prick, and they are tested for 39 genetic or inheritable diseases. These are conditions that there is medical interventions that can happen early and will improve outcomes for that child. That is run by the Department of Public Health. Our laboratory runs all of those tests, and we have a committee of experts. They're all specialists in their field, and they determine what conditions should be added to the panel. Historically, we have relied on the federal government had a committee, and they established something called the RUSP, the Recommended Uniform Screening Panel. And it was essentially a list of best practices. Here's what states should follow. In April of 2025, federal HHS terminated that committee that established those conditions. So now states have to come up with this list on their own. With that, we have seen the committee recommending more and more pilots. I believe there's 5 pilots that have been recommended for screening. And when we say pilot, every child is screened in our pilots. It's just a time-limited circumstance to determine whether it should be permanently added to the panel or not. So this is unusual. This is something that you will see during session because each of those conditions requires a budget item. There's staffing costs, there's equipment costs in some situations, reagents that need to be used for each of those screenings. So that is a change that has happened recently that I wanted to make sure you're aware of because you will be getting budget requests this upcoming session on these items. The next one I wanted to talk about is our low THC oil program. So that program was created in 2015 during that legislative session when Haley's Hope Act passed and had DPH create a registration system for patients. At the time in fiscal year 2016, we were funded $288,000 to run that program, to establish the IT infrastructure for the registry, to print the cards and distribute them to patients, as well as the staffing cost for customer service representatives to answer phone calls and help patients through the process. Since that time, our funding has been level. We received additional funding in amended fiscal year 25 when you all passed legislation requiring us to mail the cards to patients because we did not have funding in our budget to mail cards. So the legislature put in $437,000 at the time. That has now been added to our base budget.
Did they get the cards before they were mailed?
We would drop ship them in groups to health departments, and they would come into the health department to pick them up. So we were trying to cut down on mailing costs, so we would group them together and ship them for pickup. Now they are shipped directly to the patient, and you all funded the ability for us to do so. When Senate Bill 220 passed, there was language requesting that the department create and issue e-cards. Obviously, we don't have funding with $288,000 for staffing an IT system and printing cards and mailing them to be able to do that. So I know that is something the dispensaries are interested in. You may hear from them at some point requesting funding for an e-card system. So we're working through what that is going to look like, but I just wanted you all to be aware of the funding within the program and this ask that I know will likely be coming. And the last one I'm going to talk about is our home visiting program. I do hope you've all heard about it because we love this program. It provides wraparound care to mothers prenatally as well as postpartum in that first year of the child's life. So not only do they provide social supports, but they also provide clinical care. So they'll go in and they'll do blood pressure checks, urine dips, listen to fetal heart tones, and catch any scenarios where there may be a mother that is in medical distress and get them to care quickly. And we've had several documented cases of women and babies' lives being saved by this program where if the child didn't get to the hospital after the home visitor was there, they likely would have a very poor outcome. And you'll hear from that in the video that Graham will pull up and play, and then I'll talk a little bit about our funding and where we stand right now with the program, but that is something you will likely hear about again in this upcoming session. It's the DPH home visiting program.
Being in this program is an extra set of eyes on you, on your baby, mentally, physically. I don't think I would even be here if it wasn't for them. And I mean that with my whole heart. And my daughters, one of them has health issues, and she would be not okay without this program helping me push and fight for her.
It was really birthed out of this desire for Georgia to tackle this maternal mortality problem, meaning that you're more likely to die while you're pregnant, while you're giving birth, or within the first year after you give birth. There are some unique ways that you can address maternal mortality, and the home visiting program is one of them.
The DPH home visiting program is a gold nugget within public health. It is so unique because we are allowed to go into patients' home and develop a rapport so that we can serve them through clinical assessments and meet their needs holistically.
We're bridging that gap where we bring healthcare to their home. It's making healthcare a lot more accessible. Prenatal care, postpartum care, and infant care. My job entails clinical assessment, including blood pressure, heart rates, really anything.
Our patients and providers know we're just an extra set of eyes and ears. If there's an abnormal test, we call the office and talk to the nurse and let them know. If there is something going on at home, we can find that gap and close it and get them the expedited care that they need.
We have utilized this program for some of our patients who are very high risk, patients that have, history of hypertension, diabetes, previous history of preeclampsia.
It could also be a social or socioeconomic problem. It could be a substance abuse problem. It could be a mental health problem.
By us meeting them where they are, we're better able to sit down, provide education, those prenatal warning signs, postpartum warning signs. When is it time for me to call my provider? When is it time for me to be seen in an emergency capacity?
I did not know what to expect. I was nervous because I was like, okay, this is going to be here at home. She made me comfortable. I was able to just be me. My whole family got used to Lexi coming over after the first visit, and they were like, oh, hey, Lexi. Like, she joined our family.
They're able to see how above and beyond we're willing to go to get them the things they need, the items they need for their baby or the items they need for themselves.
There's a lot of up and downs, but she was there through everything. She came and gave me a lot of information that I did not know. I'm able to have that knowledge, give it to the next person, like my sisters. I can pass on that knowledge to them and be able to help them through their pregnancies.
This is my third pregnancy with them now. They helped me with getting breast pumps. They helped me with car seats. They helped me with anything that I needed. They have been there through the hardest parts of my life.
We don't just follow the moms while they're pregnant. We don't just follow them while they're delivering or right afterwards. We follow them up to the kid's first birthday. We've had newborns that have had medical emergencies where if they had waited another day, very easily could have been fatal. But they were identified through this program, transferred to a hospital or to someone that can address their needs, and they did very well afterwards. When you see that happen enough times in a very short period of time, you say, this program is working, we need to keep doing it.
The impact is probably even greater than we would, imagine. It's providing multiple visits and points of contact with our patients, but also increasing that trust. When you bring care to them and show that you truly care, that does make a world of a difference to our patients.
You can't pour into your kids from an empty cup. And they helped me learn that. If you're not okay, you can't be the best mama you can be.
It benefits the entire community when you have healthy moms and babies. I think this is the future, not just for Georgia, but for the country.
I love that video. The commissioner cries every time she watches it. So we have now expanded this program to 115 counties after the fiscal year that started July 1st. The last budget had a planned expansion of adding an additional 33 counties, but looking at the population and the ability of us to share resources across counties, we were able to actually add an additional 7 on top of what you funded. So the southern half of the state is covered. I know the gleam and the commissioner's eye is for this to be available statewide. So we're getting close. It's a great program. So I'm happy to talk about that or any other questions that you may have.
Thank you. That was encouraging. I had one question from earlier, House Bill 89. You mentioned the regional perinatal centers. And of course, we heard from DCH earlier talking about the obviously need and regulatory roles. I'm just wondering how do the two entities, DPH with regional perinatal center evaluation or establishment? I know I look across lots of areas of Georgia, especially below I-16, where there are challenges. I know it can take a while to get somewhere in DeKalb County too, but the distances are certainly further. I'd be interested in seeing how that works with either health planning with the regional perinatal centers, obviously addressing maternal, both mortality and morbidity, just illness is important along with the child. I think I'd be interested to see how the two groups work together. If you've got any information on that later.
Yeah, we collaborate with DCH regularly. We actually meet with them once a month, personally, the commissioners, about maternal and infant issues. And this is something that we talk about, especially as that bill created a committee to make recommendations to you all on what the regional perinatal system should look like. And there was recommendations that were sent to the Speaker's office in June. I'm happy to forward them to you as well for the committee's use. And they're going to be continuing to meet because there's more work that needs to be done.
We mentioned, obviously, this is high risk. By the way, that home visit is prenatal and postnatal?
Yes.
Okay, yeah, because there was a question about, and I know we're talking about EMS at our next meeting, because that, transferring 2 or 3 hours away for a small county can be a challenge.
Yes.
to transfer someone to a perinatal center for higher risk deliveries, whether people should even be there a week ahead of delivery time would be safer and more efficient.
Yeah.
Anyway, but thank you for that. Representative Mitchell.
Yeah. Very quickly, Mr. Chairman, I must say, Assistant Commissioner Andrews, that whatever you're paying Graham is not enough. Could you let the commissioner know? I happen to serve on a national committee with the NCSL, that's your Compass State Legislators, which he is a part of, and he showed this program, and it was universally just received raves nationwide. And I just want to think that this is a great program you're doing.
Thank you so much.
No.
Yes, absolutely. Absolutely. Thank you.
Leader Seabaugh.
Thank you. Thank you, Megan. Thank you, Graham. You're of great assistance during the session, keeping us educated on issues important to public health. And I know I appreciate it and can probably speak for the entire General Assembly, but I know you're glad when it's over too. Can you tell me how many counties have public health departments that are struggling? There are a lot of them.
Yeah, every county has a health department, which is a challenge in some of the smaller counties that have small populations and little resources. I can't give you a number of how many are struggling, but I know that it's a challenge with staffing and having sufficient resources in order to have all of the services that are necessary, especially at some of those smaller counties.
And do the regional, I say regional hospitals, but the hospital that take the patients when they need to go to a hospital,
Yes, yeah.
do they help these struggling public health departments at all?
They serve as a resource for accepting referrals. If there's someone that needs additional care, they can go to the hospital. And there are scenarios where we refer them for support that we can't provide. For example, if a pregnant woman has an STD that needs to be treated and they have an allergy, that needs to be done in a hospital with a higher level of observation of the patient while they're being treated. So we do work collaboratively with the hospitals. I wouldn't say, the hospitals aren't funding the health department. That's state, federal, and local funds or fee-generated revenue that they have.
I love the home visiting program. I think I think we're going to see over the next 10 to 20 years, we're going to see treatment at home is going to be a big part of healthcare in the future. So that's a great program. Does public health or are you aware of anybody that reaches out to some of our chronically ill patients with diabetes, hypertension, normally seniors who have mobility problems, those kinds of things? Do we reach out to those people at all, or the frequent flyers, as we call them, in our business that go to the hospital routinely for the same thing?
Yeah.
Does anybody at public health reach out to those people to try to proactively keep them healthy?
We do have some of our health departments have more robust diabetes prevention programs where patients may be referred into there, and they coach them through some lifestyle changes to prevent them from accelerating in their diabetes. And I know there's some hospitals and other healthcare providers that do home visiting targeted to those individuals with chronic illnesses. It's not something that we do currently in public health. Our target right now is in that maternal, prenatal, postpartum period, but certainly open to discussion about other opportunities.
Okay.
Mhm.
Because part of the purpose of this committee is to try to find solutions to problems that we have, and chronically ill patients are a problem for hospital visits, and we're just not keeping people healthy, and people have to take personal accountability for their health.
Mhm.
But we know we have a population of those folks that don't. So just be thinking about maybe how we could do something like this home visiting program for some of these chronically ill
Yeah.
folks as well.
Yeah.
I just want to put that out there for discussion, but
I will say it wasn't highlighted in the video, but one of the unique things about the program is we work with nurses and community health workers. And that's one of the ways that we're able to have such low costs in order to have access to services. So there's a nurse that's supervising everyone, but there are community health workers that will go out and do the visits, especially if it's a primarily educational visit, and they can do some minimal clinical checks like blood pressure and things like that. And it's a way that we're able to have reduced workforce costs in order to be able to expand the program.
thank you.
Chairman Taylor.
Thank you, Mr. Chairman. Thank you for this presentation. It's very, very good. I think the department has been long overlooked as the key part of the state's health programs. And I think we do need to beef it up some. It's a resource. It's in every county. I will share in my community, our department refers to the FQHC. They're just down the street. They're actually connected in a building, and they often are referred if they need continued care. Getting that medical home for a patient is so vital. But again, this is a thank you. It's not been that long since COVID and what the state went through in the country, and you were in the front and saved lives, kept things going throughout the communities, and to this program now for our maternal health care. You've been right, spot on, and I'm very grateful to Dr. Toomey and the department for what you've done. What's next? What do you need more of? And how can we as a legislature help you?
Yeah. I mean, we love this program. We'd love to see it accessible to all Georgians. We're getting closer. Like I said, we're in 115 counties. It's primarily the north and metro areas that don't have this service yet. So that's something that we would love to see in the future. I think it's also served as a model for other states. Like Representative Mitchell mentioned, Mississippi is mirroring our program, and we are also collecting data. Emory is helping us with data analysis in order to prove its effectiveness, and in hopes of being able to secure federal funding too in order to further expand the program. So that's our number one ask and has been over the years, and we truly believe in the impact of the program.
Thank you.
Yeah.
Certainly that population of talking about early or pregnancy and perinatal and the year following is something we have, as we mentioned earlier, expanded to 6 months and then a year after delivery. Hopefully, maybe working, I don't know if there's an additional waiver to get a higher rate to do the home-based services when they're carefully delineated on what the circumstances are, but certainly that is a population. I believe it's over 65% of our births in Georgia are on state Medicaid funding. So certainly we'd love to see how the two can work together to when it's appropriate to do the home, to go to the patient, to encourage it. Certainly wellness is something being incentivized in the commercial plans as well with Medicaid, Medicare, accountable care organizations and others.
Yeah. And we do bill Medicaid for the Medicaid billable services now. It's certainly not enough to sustain the program, but that is a topic of conversation that we continue to have with DCH in our monthly meetings about how we can improve reimbursement for the services we provide through this program. Yeah.
Thank you. Representative Buckner.
Thank you, Mr. Chairman. This is kind of a rambling question, but it used to be that at a lot of the health departments, there was a program called Safe Kids, and that had a lot of safety information, educational, car seats, bike helmets, but injury prevention as well. And I'm interested in knowing if that program is still in some of our public health departments and if some of those curriculum are included in the home visiting program. And the reason for my question and we need to work together on this. I received several phone calls from area pediatricians, emergency room physician, that some young kids, very young kids, got into some THC gummies and OD'd over the 4th of July weekend. Fortunately, they all survived, but there were several that had to be hospitalized. So I just want to make sure we're doing safety and injury prevention at the visiting, because you can see something in a house sometimes and be alert to that. And I was just curious about where is the Safe Kids program now?
Yeah. So a lot of the services that you mentioned in education is still housed within DPH and available in the health departments. It's our injury prevention program. They do car seat education and help do installations at some of the health departments. And if someone is low income and can't purchase a car seat, they'll provide a car seat that's safe for that child. As far as how that overlaps with the home visiting program, it is part of the curriculum. So I love that you brought up that when you're in the home, you can identify something that could be a problem that a pediatrician would never realize in the office setting. So safe sleep is really important. So we make sure that the child has a safe space to sleep that isn't filled with blankets and stuffed animals, and coach parents through how to have their child safe sleep. We also have resources to provide cribs or like pack and play type situations if there's someone that doesn't have a safe place for their child to sleep. So that is definitely incorporated into the program. And then what was your other question? We had one more.
We need to do something about
the THC. Yes. The composite board has started creating work group meetings to actually discuss this issue. So I'm sure Jason would be happy to talk more about it when he presents later this afternoon. But their board chair, Dr. Cheek, is also on our board. And so she's been bringing all of the relevant parties to the table, including us and Department of Ag and the Cannabis Commission, as well as the Poison Center and healthcare providers, in order to discuss the issue and figure out what the best approach is to address it. So they are definitely working on it.
Great. Thank you.
You're welcome.
And with that, thank you to what Megan, what you and Graham and Dr. Toomey do to keep all Georgians healthier, but in particular, some of our most vulnerable in those 159 counties that are working sometimes thankless jobs. Thank you from us, and thank you for presenting this morning. We're going to take a break until 1:00, and after which we'll hear from Georgia Board of Healthcare Workforce, Department of Human Services. We're going to hear from the Insurance Commission and the Georgia Composite Medical Board, as you just mentioned. So look forward to seeing everybody at 1:00. Afternoon, hour of convening having arrived. We'll go ahead and get started with our afternoon session. Appreciate the morning presenters as well as several of these after lunch presenters. We're going to start with the Georgia Board of Healthcare Workforce. Chet, if you could come on up and if you'd like to use the podium or you'd like to use the desk, either one, whichever is better for you.
If it's okay, we'll use the podium just to control the slides.
No, that's great, and glad to have you. If you don't mind just introducing yourself to the committee and those that might not have met you before.
Absolutely.
Thank you for being here.
Good afternoon. I'm Chet Basine. I'm the Executive Director for the Georgia Board of Healthcare Workforce. I want to, is this better?
That's better.
All
Sorry.
right. Starting from the top, Chet Basine. I am the Executive Director for the Georgia Board of Healthcare Workforce. I've been in the role for a little over 4 years and appreciate y'all inviting us down today. And we're really happy to present. And to my left is Alex Moses, and she'll introduce herself.
Perfect. And thank you all very much, members of the committee. My name is Alex DeVay Moses. I'm the Externals Affairs and Program Lead for the Georgia Board of Healthcare Workforce, and we're happy to have the opportunity to be here. All right, and for our agenda today, we will discuss the mission and vision of the Georgia Board of Healthcare Workforce, our budgets, the past 5 years and our highlights, growth opportunities, recent bills that have impacted the Georgia Board of Healthcare Workforce, data of note, and then we'll wrap up with questions that you guys have. All right, so for our mission at the Georgia Board of Healthcare Workforce, it is to identify and address healthcare workforce needs with an emphasis on underserved communities. My apologies. As well as for our vision, we see that Georgia communities, especially in medically underserved areas, have improved access to needed physicians and other healthcare professionals, thereby enhancing the health and well-being of Georgia citizens. And now we will go ahead and discuss the Georgia Board of Healthcare Workforce's budget and our programs. We have 6 distinct programs. The first being our administrative, which is under 2% of our budget and covers salaries, technology, and other operating expenses. For Mercer School of Medicine, this program covers items specific to Mercer and a public-private partnership that supports the education of physicians to meet Georgia's primary care and health needs. Similarly, Morehouse School of Medicine, this program covers Morehouse-specific items. It's also a public-private partnership supporting physician education. And it's worth noting that Mercer and Morehouse are unique that neither of them operate their own hospital. Next is the healthcare education programs, which funds 2 things. First, our medical student capitation payments at roughly $6,300 per medical student. And secondly, our nursing school grants that administers $3 million in total to nursing programs across Georgia. And these grants grants specifically help programs with enrollment waitlists expand their capacity so they can graduate more nurses for Georgia. As for the graduate medical education, or GME, this includes residency capitation payments, GME exploratory grants, and fellowships. The residency capitation payments strengthen the supply of primary care physicians and essential specialists at more than 25 institutions statewide. We currently fund approximately 23 slots with an additional 1,200 slots that exist but not funded by our agency.
Tell us more about that later, right?
Yes.
Okay, thank you.
As for our GME exploratory grants, these function as feasibility agreements, allowing institutions to assess the potential of a GME program before making a larger commitment. And to date, we've administered more than a dozen of these grants. And finally, our healthcare practitioner loan repayment program, which is actually a family of loan repayment programs covering physicians, dentists, APRNs, PAs, nurse faculty, behavioral health practitioners, which includes psychiatrists, psychologists, and other occupations. And we are very happy and excited to introduce optometrists into this. And we want to thank you for signing HB 659 that does include optometrists into our service countable loan repayment program.
Well, just one amendment to what Alex just said. She said we fund 23 slots. We fund about 2,300 GME slots when she was talking about that. So I want to make sure that that number gets recognized. But transitioning on to the past 5 years programmatically, the agency has been quite busy, and we want to thank members of the General Assembly, such as yourself, for that. We appreciate you trusting us with taxpayer resources and trusting us to execute on this work. What you have in front of you in this slide is a series of bullet points that have definitely, we think, benefited Georgians everywhere, corner to corner in the state. First and foremost is the Nurse Faculty Loan Repayment Program. This is a service cancelable, so this is a loan repayment program for nurses who are full-time educators to the nurses of tomorrow. They can earn $25,000 over a 2-year period. That program has been wildly popular. Every year we find ourselves having more applicants than we have available funding, which is it's good to see it so popular. A moment ago, Alex mentioned the nursing school grants. That is annually we have about $3 million in our budget for schools with additional capacity but wait lists. We have issued awards to a couple dozen schools, or I should say programs, really, around the state. Some schools have won it across the different programs, and it's really allowed for additional nurses to enter into their training in order to become practice ready. A moment ago, she mentioned HB 659 that got recently enacted. That is allowing optometrists now to be included in our service cancelable loan program. So we will be standing that up here in the next couple months in terms of the application season and allowing them to apply. And generally, just for reference, we open up applications in the late summer, early fall, but we do not announce winners till about January of the following year. So in January of 27 is when those winners will be announced, just from a timing perspective. Carrying on in Senate Bill 480, it allowed us to administer $850,000 in the Georgia Behavioral Health Loan Repayment Program. That is a series of behavioral health practitioners that have been able to apply and earn awards. We've got psychiatrists, psychologists, nurse practitioners, social workers, behavioral analysts, and more in there. So it's really allowed us to service that whole spectrum of healthcare workers. And then the next two bullets you'll see is the multi-year physician and dental loan repayment program. That allows us to do loan repayments to for physicians. If you're in your final year of residency or fellowship, you can earn a 4-year scholarship award. This is actually the first year we did it. This past fiscal year, we had a few of those awards, so we were able to, what we believe is, retain these physicians in Georgia, and they're in a geographically compliant area of the state, which really means a county of 50,000 or less. I also want to say we were able to do that for dentists. I want to thank Chair Hawkins over there. I know you were part of the champion. You were a champion for that. We were able to retain dentists also in the state of Georgia, as long as they're in their final year of dental school, they can apply for our loan repayment program. And if, again, they have to be in a geographically compliant part of the state, which again is the 50,000 or less on the population at the county level, we are able to keep them in their communities to treat patients.
Could you explain that one more time on when does somebody apply for or get awarded that, and what is it?
The dentist and the physicians?
Yes.
Yeah, they're glad to. It's a great question.
Final year of residency?
For the physicians, your final year of residency or final year of fellowship. And then they apply when they start it. So really about this time, in a few weeks, we're going to open up our loan repayment applications. They will apply, and then we will give them the decision in January. And then they can graduate knowing that, hey, I have this up to $150,000 of loan repayment as long as I work in a compliant area of the state. So that's how it works for the physicians. The chassis is very similar for the dentist, except with the dentist, you apply as a fourth-year dental student right in the beginning of your D4 year. And then we give them notification right around the January timeline of their D4 year. And then they can kind of carry on and graduate as we assume they intended to. That's a great question. Last couple things I'll just point out there on this slide, because it's, we've really been busy. So thank you for allowing us to do this great work. We've been able to administer funding for actually a little over 300 more GME slots through the capitation program. This goes across the 25 or so different sites that Alex mentioned moments ago, across a multitude of specialties. And then last but not least is the Healthcare Workforce Online Dashboard. That stems from HB 1013 and SB 500. We are towards the final stages now of publishing or getting the data so we can publish it. I anticipate that will be live, meaning a member of the public, the way the bills were written and enacted, will be able to pull down the data from our website probably late this year, early next year. I want to thank, I know the medical board is in the room. I want to thank them, but not just them. It's really been across the board, medical board, all the different boards at SOS, pharmacy board. So SOS has been great to work with, and GDAC has also been part of this. So it's definitely a team event here. That's a nice segue to kind of show you what else we've been up to over the past 3 years, the data. So pulling aside the HB 1013 and the SB 500 to formulate the healthcare workforce data set, we actually have just published a lot of healthcare workforce data on our website that is accessible to anyone. You will see a lot of data pertaining to physicians, PAs, dentists. We actually did dental hygienists for the first time. Optometrists, pharmacists, pharmacy techs, and registered nurses, definitely last but not least. So what we really are trying to do is paint a full picture of the healthcare workforce. Again, we can't do this without the licensing boards. They've all been wonderful to work with. And then also without GDAC. So it's been a great three-way approach. We also published all the match results for the medical students. Actually, we have our board meeting later this week. We'll be presenting that at the board meeting, so we'll have that soon. And then we have the GME dashboard, where again, we receive a exit survey from, I would say about 900 to 1,000 graduating GME individuals annually. And then we ask them a series of questions, and then we aggregate it, de-identify it, and then publish it. So everyone can use it for performance improvement. So that's kind of what's been going on at the agency now for the past few years, 3 to 5 years, budgetarily, legislatively, operationally. And I was also asked to come to y'all. I'm going to transition to the next slide. Opportunities for growth. Healthcare is so wide and it's so expansive, and it always is changing, which is actually some of the fun part of healthcare. We historically, for those of you who are familiar with the Healthcare Workforce Board, been very physician, dentist, PA, APRN, and behavioral health more recently centric. We perhaps could look at doing some stuff with additional healthcare workforce entities, whether that be from a licensure, a place of service. We think there's opportunity there. It just depends on like where the needs are from the state, and we want to make sure that we're in sync. So that was one idea that we had. Another is research opportunities and collaboration. One thing we actually were successful. I wanted to share this with the group through awareness from the Georgia Composite Medical Board earlier this year. They made us aware of a grant opportunity with the Federation of State Medical Boards, FSMB. We went and applied. We actually won the grant. So we've done the paperwork, and we are going to work on advanced practice providers in terms of supply and distribution, and their utilization here in Georgia. Again, it's a main partnership with GCMB supplying us the data. We think we can do more of that. We did that with in-house resources, but if we had perhaps more resources, we could do more of that. It is not uncommon to see other state workforce boards engage in such work. And then that kind of transitions to funding opportunities, which was another request of this presentation. Earlier, I mentioned that through HB 659, optometrists were added. There was no funding added, but we will still administer the program, and we have a base set of funding that we can use to include the optometrists. But I just want to make you all aware. And then again, as I mentioned, with the Federation of State Medical Boards, we could engage in other activities of similar kind, perhaps with additional resources. So that, in a nutshell, is kind of the who we are, what we do, what we've been up to for the past few years, and as part of this summer update that I appreciate y'all inviting us to. And Chair Newton, I'm glad to answer any questions of the committee.
Well, thank you for that, Alex. And Director, I do think there's some excellent thing. I was just looking at your section on data additions for the past 3 years. I imagine we have somewhere in there the website to get to it, or the
Yes, you can go. It's our website, and then actually Alex is the keeper of our website. We have a data button on top, and then it just takes you there. And it's an online dashboard.
How do you deal with the challenge that you're making? You're trying to improve our healthcare workforce, physicians and others, dentists, but it takes a long time, especially if it's in medical school. By the time you're not going to know if that intervention during medical school or even early residency resulted in an increase, a better percentage of retention of GME or whatever. Does that site now go back several years, or is it only you had to have a starting point for the data, and it wasn't even available or collated from, say, 5 years ago? If we wanted to compare next year to 4 years previous, could you do that on that, or is it not really?
It's a little bit of both. We do have some retrospective data in terms of, let's just use physicians for the sake of this example. The amount of physicians we had licensed by specialty at certain date intervals, we get the information from GCMB. So we follow their 2-year cycle of relicensure. But then the second part of your question, if I heard you right, was the retention of GME. That we do through another avenue. And actually later this week, we'll be sharing some information where we show over the past few years, we actually have had an increase. We have a report where we have stitched together the GME graduates in Georgia. We do a 5-year retention every August or September. Our data team puts out the notice to the programs that we contract with, and then they provide us with information so we can do a 5-year retention of, it was Dr. So-and-so, is he or she still in Georgia? And then we do a 5-year calculation off that. And I can tell you the trend line is showing an increase, not just from the percentage, but even from the total N now of the graduates coming out.
Okay, now that would be on a special report, or it's just available on the website, or?
It is a special report, but I will get you a copy.
Okay, no, I appreciate that. That is a certainly a challenge, and I know your group's tasked is with underserved areas primarily. Is that right, or just the state as a whole, or a little of both?
Well, I would say that it's how you choose to define underserved, I think, is the question. We from a loan repayment perspective have the rule of, if you're the most recent census, which is 2020. If it's 50,000 or less in population, then we define that as the rural underserved. But then with the behavioral health loan repayment program, we use HIPSA to make sure it's a mental health, it's approved as mental health. And then we look at the scores there in terms of like how much of a need there is. I think the scale is, we're not in the season right now, so I'm not fully up to date, but I think the scale is 1 to 26. The higher the number, the more the acute the need is. So we use that figure as a guidepost.
Thank you. Representative Seabaugh.
Thank you for your presentation. Do you know how many counties still have no primary care doctors?
I don't have it memorized, but I do know that that is some of the data that our data team, when they look at family med, internal med, and all the different specialties. So we can definitely pull together a short list by specialty, and I'd be glad to send that to your office for your review.
Right, thank you. And I just wonder what what incentivizes a new doctor to want to work in a county of less than 50,000 people and probably have no other colleagues there?
Is it those rate studies that we talked about with Medicaid?
Yeah, I think it's an excellent question. I mean, I can just tell you what I've heard. Representative Seabaugh is some folks are just drawn to rural health. They grew up in a community like that. They realized a passion. Others, we have a board member today. He hails from Metro Atlanta, but met somebody from down south in Georgia, and she took him down there. Others might have high levels of debt. We do know from our loan repayment program that the average tends to be around $250,000 for our applicants. It vacillates a little bit every year, but we're in the ballpark. And then if we have a $150,000 service cancelable program, that might be attractive to certain individuals. Sometimes it's a combination.
Yeah, and just one more. Are these doctors required to accept Medicaid patients?
Absolutely. That is listed clearly. They have to not only accept Medicaid, they have to also not actively restrict. Again, I have to look at the contract, but we were very deliberate on the agreements to make sure that Medicaid recipients would not have any access issues with our loan repayment winners.
Thank you.
Chairman Taylor.
Thank you, Mr. Chairman. Appreciate the information sharing with us today. I'm particularly interested in the residency program. And again, rural communities, how do we get the folks to be exposed to it? Is there any way that we can put either in contracts or working through the medical schools where they can have a round of training when they're residents or even when they're interning, that they do a tour with both a rural community and through public health? I think we're lacking in doctors going into public health. And is there a way to expose them more? Is anything like that included in your contracts?
There is a clause in there in a couple of the agreements. I don't want to misspeak in this situation. I'd have to go back and look, but a couple of them do stipulate that you would expose, I believe it says something to the extent of you would expose or educate your students or individuals on the benefits of working in rural medicine. So we do have something there. Is it a formal curriculum that comes out of our office? No, it's not that, but it's not there.
Are we tracking those that are going and ending up in the rural or underserved areas? And again, it goes back to the question, I guess I'd like some brainstorming on how we can incentivize them. It's one of those things, it seems like that's where we're needing physicians and other medical providers, but how can we incentivize them and expose them to the possibilities and what's offered in these communities?
It's a fair question. I'd love to have that conversation with you.
Okay, thank you.
Chairman Hawkins.
Well, I've got a question for you, but just to follow up on Chairman Taylor's question, we do have residency programs in the state that are sending their residents out for part-time to the rural hospitals, like an exchange kind of program, and they are moving through. I know Mercer's doing that and some other programs are doing that. So it's working out well. And I think we'll see an increased movement in that area. Yeah. To chat, a couple of years ago when you and I sat down, we were looking at these loan programs, and they were actually loans that were not utilized because of the way they were set up. We were notifying students, dental students, and then post-residents, after they both left their programs, that they had been accepted into the rural. And that's sort of late when you're already out of school and you're out of residency. Typically, you're looking for a job the day after you get out. So we changed that to the senior year of both at in dental school and then the graduate. So my question is, since we've done that, do you see any of those loan programs going vacant, or are we taking advantage and filling those slots up?
In holistically, Chair Hawkins, you're talking about the entire loan repayment or just with the dental spectrum?
No, holistically, dental and medical.
I would say that as we got out of the COVID era, because it was a little bit different then, as we cleared 22 and 23, we have seen the how do I say it? The interest in it go up. The biggest challenge, if being quite frank with you, is we get a lot of applications, like a lot. What happens is when we say to the applicant, hey, you're missing this, then some of them just go unresponsive and don't give us the information we need. It might be a signature, it might be a loan statement to validate their balances. And we try, we text, we email, we call. That's where there's the fall off. But like that initial interest is heavily there.
Good. Thank you.
I can tell you, you said January is when they get final notification.
We traditionally in our January board meeting, which is usually towards the end of the month, the board approves the slate of prospective awardees, and then usually within a few days to a week, they're given a notification. They're presented their contract usually within 2 to 3 weeks of the board meeting. They have about 10 days to review it, so that's the month of February. And most of the applicants, when they get their contract, are fairly responsive. And then once that comes in and some supporting information we need, because it's been a minute since they applied, we start processing checks. And the majority of the checks start to go out between May and June and July is kind of how it works from a time perspective.
Just one consideration. I do know just physicians in their last year of residency, and I imagine in the last year of dental school, are often looking for jobs in October. And if we're really wanting to influence them, with some certainty, I don't know if there's a way to push that back just a little bit more, but I can tell you, just having sons that have done that, and spouses that want to make sure that they go on and sign for a job. And if it does sound like it's a strong program. Just a consideration.
I agree with you. And we actually this year are opening up the application sooner. It's being updated and digitized some more. So we're just waiting for that. So years past, we tend to open it up like late summer, fall, which is that early September time. But we're really going to open it up this year around August 1st, I think is what we're aiming for, so that we're going to pull it ahead a little bit.
And that final board meeting might be, or which one that approves it might get moved up.
Since we're on the topic, I'll let you know what we're trying to do. We are trying to bring some, maybe not all, some winners to our October board meeting. So it all depends on their ability to get the application in. If they're missing something,
certainly,
for us to then say, hey, we need this, and then to reply in time. Now, again, this is our first year trying it. But we're going to have to cap it at, let's just say everyone's compliant. We're going to have to cap it at a limited amount because we're trying to pull that forward as well.
Chairman Leverett.
Thank you, Mr. Chairman. Thank you for your testimony. I just had one quick question. Earlier, I think in your testimony, I'm not sure if I understood you correctly, but I thought you were saying that the definition of an underserved community turned upon its absolute population.
That is it's a great question. It's on the majority, not all, but the majority of our loan repayment programs. Your 2020 U.S. Census population has to be 50,000 or less.
For what division? County?
At the county level.
For the county level. Okay. All right. Thank you.
Sure.
Right. Thank you for your presentation. Thank you for your work and for the lives that will be improved by it. Thank you.
Thank you for having us.
We're gonna move on to Department of Human Services, and if you can come on up, you're welcome to either the podium or the table. Mr.
Yes, ma'am.
Yeah, someone's got both mics should be working there. If you don't mind, we got our. Feel free to start whenever you're ready and give us a intro and proceed.
Sounds great. Good afternoon. My name is Melody Debussy, and I'm the Chief Policy Officer at the Georgia Department of Human Services.
And my name is Brian Pedersen. I am the Deputy Commissioner in charge of the Office of Health Law and Policy at the Department of Human Services.
With the presence in all 159 counties, DHS touches the lives of more than 2 million Georgians each year. Today, we're going to talk about some of our programs in each of our 3 divisions and walk through some of the legislation requested. We also have in your packet a sheet that goes through some of the key legislation that we won't cover today necessarily, but have for your reference.
Thanks. Thank you for the exhaustive list as well. We may have some on the committee that are interested in specifics that might follow up with you. Thank you for that.
Yeah, absolutely. So the best way to break down our mini services is to look at those 3 divisions and DHS. The Division of Aging Services assists older adults, at-risk adults, persons with disabilities, their families and caregivers to achieve safe, healthy, and independent and self-reliant lives. The Division of Child Support Services increases the reliability of child support paid by parents when they live apart from their children. And the Division of Family and Children Services investigates reports of child abuse, finds foster and adoptive homes for abused and neglected children, issues SNAP and TANF, and determines the eligibility for Medicaid, and provides numerous support services and innovative programs to help families in need. In Division of Aging Services, or DAS, we support older adults, people with disabilities, and caregivers through a variety of services, such as delivering meals to homes, providing legal assistance, and offering Medicare counseling. The division also investigates cases of abuse, neglect, and exploitation for both elder persons and adults with disabilities. I'll highlight 2 DAS programs. In Adult Protective Services, we investigate all reports of abuse, neglect, and/or exploitation of older persons, 65 and older, or an adult 18 and older with a disability who do not reside in long-term care facilities. In our State Health Insurance Assistance Program, or SHIP, our trained counselors will be able to assist callers with questions on Medicare enrollment, Medicaid, or even private insurance. In the Division of Child Support Services, we administer our state's child support enforcement program. In addition to establishing and facilitating child support payments through establishment orders based on the Georgia Child Support Guidelines, DCSS also incorporates an establishment orders for the responsible health coverage and uncovered medical costs. If either parent can get medical insurance for the child at a reasonable cost, the court will consider that cost in deciding the amount of child support awarded. Usually, if the non-custodial parent can get health insurance at a reasonable cost, that parent will be ordered to obtain it for the child. So as a general. And finally, in the Division of Family and Children Services, or DFACS, we support 2 offices with a mission to prioritize the safety of Georgia's children and the decisions we make and the actions we take. We also partner with families on their path to independence and build stronger communities with caring, effective, and responsive service. In the Office of Family Independence inside of DFACS, we operate eligibility programs, including eligibility for family Medicaid, the Age Blind and Disabled Medicaid Program eligibility, Peach Care for Kids eligibility, and Georgia Pathways eligibility, as well as manage the Georgia Gateway Integrated Eligibility System, so how all of the clients apply for public assistance benefits. And support programs within Georgia Gateway for the Department of Early Care and Learning, CAPS, and Department of Public Health, or WIC, that Ms. Andrews talked about earlier. OFI also operates the Supplemental Nutrition Assistance Program, or SNAP, the Temporary Assistance for Needy Families, or TANF program, and in partnership with the Community Action Agencies, administers the Low Income Home Energy Assistance Program and Community Service Block Grant funding. Here is a brief look at some kind of recent eligibility workload for our Medicaid eligibility staff within DHS, providing eligibility determinations for more than 1.8 million recipients. As part of our partnership, DHS and DFACS Fair Hearings staff and attorneys also support the eligibility fair hearing process when an applicant or a recipient asks for a review under their right to appeal an agency action and receive a hearing regarding such action. The Office of State Administrative Hearings, or OSA, provides rulings in these cases that are not able to be resolved by DHS administrative staff. Brian will talk about the Office of Child Welfare.
Sure.
In the Office of Child Welfare, DFACS promotes and protects the welfare of children by receiving and investigating reports of suspected child abuse, providing protection for children who are victims of abuse, providing services to families to increase caregiver protective capacity. DFACS also provides for the temporary care of children whose families cannot ensure the safety or meet their basic care needs. When children cannot remain safely with their parents, DFACS recognizes that children thrive best in kinship care, and through its kinship continuum, prioritizing placements with kinship caregivers as preferred and best option for children. Kinship care is the full-time care and nurturing of a child by a relative or fictive kin. Through adoption support services, DFACS focuses on finding safe and permanent families for children when permanent legal separation from the family is necessary. Adoption practice provides sound planning for children who have a permanency goal of adoption and children who are in the permanent custody of DFACS. And DFACS has the responsibility to recruit adoptive families who will meet the needs of a variety of children. Finally, through prevention and community services support programs, DFACS provides an array of services designed to preserve and reunify families involved with or at risk of involvement with the child welfare system. The services include early intervention, parent aid, prevention of unnecessary placement, homestead and wraparound services, promoting safe and stable families, and linking parents to DECAL, provided child care caps resources. Foster care services focus on strengthening and rebuilding families to facilitate the child's safe and timely reunification with their family. When reunification is not possible within a reasonable period of time, foster care promotes the permanency of the child by arranging for placement in another safe, stable, nurturing home. While in care, the comprehensive needs of the child are assessed and services are arranged and provided to promote their well-being, including supporting health and dental care. Health and dental care, I will say that this legal authority, this duty is brought upon the department as a result of OCGA 495311, most specifically subsection C, the responsibility to provide the child with food, clothing, shelter, education, and ordinary medical care. That's how DFACS becomes a de facto healthcare agency under its duty of law. On this slide, we're going to talk about our medical treatment denial appeals. And let me give you some context on this because this is just raw numbers. When I came to DFACS in 2022, we had an issue with multiple problems involved. We had children that were being denied for medical services by the medical provider. We also had children in hotels who were in need of medical providers. And we also had an issue with overburdening our caseworkers with administrative work. With the commissioner, we formed a plan to basically streamline that process, centralize it. And what we have done is formed a small legal team within my office, and they literally review every denial or change in circumstances for every foster children in DFACS custody on a daily basis. And if there is medical necessity, they will appeal those cases, forced to the CMO as part of an administrative appeal. And if medically necessary, we will file fair hearing cases and ask for a hearing in front of the Office of State Administrative Hearings. As of last year, they did 802 administrative appeals. They did 229 fair hearing requests. And since we have been tracking this since fiscal year 2023, they have recovered $1,583,000 in state funds.
Who is it? Who's denying the care?
This would be the CMO provider. So an application
The care management organization
Correct.
has declined a treatment or a therapy or
That is correct.
prescription. What?
That is correct. Just like any sort of normal everyday citizen of our state who has an insurance company, They ask for a treatment, their doctor fills out an authorization form, and then it becomes an issue of whether utilization management, or on behalf of whether it's a private person or whether it is somebody covered under a Medicaid policy, deems it medically necessary.
So these funds that you've received, the 1.5 million, that is for care that you went on and paid for.
That is correct.
Even though it had not been.
That is
quote,
correct.
authorized, prior authorization.
Correct. And at the very beginning of this, you'll see I reference psychiatric residential treatment facilities, psychiatric inpatient, and crisis stabilization. Those are three very high acuity, the highest of acuity of mental and behavioral health treatment. When we started, it was concentrating on those sorts of claims first, the children most in need of this medical treatment immediately. And this is how we combat it. Even today, it is a large portion of our fair hearing requests. It's an ongoing issue, but it has improved since we started this.
All right. I'm sorry. Hold on just a sec. Chairman Taylor, did you have a question now, or did you want to wait till the end? Okay. So go ahead. Thank you.
All right. So let's talk about some recent legislation. We're going to talk about Senate Bill 377, which is our Qualified Residential Treatment Program legislation. And what this law did was we had QRTPs on the books in Georgia, but our statute was out of conformity with the federal requirements under the Family First Services and Prevention Act. So what Senate Bill 377 did is it characterized Q-tips as a child caring institution under the department's authority and regulation, and also placed it in conformity with federal law. This allowed us to partner with our state Medicaid agency, the Department of Community Health. And with DCH's partnership, we have worked on establishing a pilot program. We have a male facility and a female facility, Q-tip facility, currently running. And what we have done is, because there's a component, there's a medical treatment component, and then there is a room board and watchful oversight component, we have partnered with DCH to basically braid our funding. So for Medicaid coverable services, we're getting Medicaid reimbursement, and then we're also tapping our 4E funds to cover the room board and watchful oversight. Next highlight on legislation is House Bill 1201, our Commercial Sexual Exploitation Recovery Centers, or CSERC for short. These are child caring institutions providing full-time residential care to support the services of youth through 18 years of age who are victims of child sexual exploitation. There are currently 2 CSEC programs. Right now, there's Gigi's House in Clayton County, and there's also Gracie's Place in Gwinnett County. At that time, we will cede to you all for any questions that you all may have.
Well, thank you. Thank you for that. If you don't mind, for me, it's kind of related to a question we touched on earlier regarding of the 3 roles. I believe it was the 3rd one under Family and Children's Services, and I think it involved DFACS, I'm sorry, TANF, SNAP, and then Medicaid eligibility. That got some attention recently, in particular in this past session, due to the potential penalties that are in H.R. 1 with the federal government's participation in these programs. What is I guess, do you have both the regulatory environment and the funding needed to make sure that Georgia for sure minimizes our eligibility errors or fraud errors or whatever else it is, and is in no concern for federal penalties? Or is there additional guidelines, assistance, legislation, funding needed?
Yeah, so I appreciate that question. One of the things that we were directed to do in the budget, and we can certainly share with this committee, is our report on this department's goals and kind of the targeted intentional investments that we're making to be able to operationally meet that goal of HR1, reducing our payment error rate. So we can certainly share that report that we did provide to the House Budget and Research Office as part of the budget directive. So part of the things, I won't go through everything that's in that report, but it includes some kind of specific training and directive staff, like nesting programs that we're doing, and also analytics, right? We're using a lot more technology to understand the types of errors. I think what most people don't understand maybe about the payment error rate is the way that we work with the USDA to define our quality program doesn't have necessarily the same, basically client errors and staff errors both count against us, underpayments and overpayments. And so we always want to run an accurate program with the most program integrity possible. But we've been working and having dialogue with our federal partners, both about flexibilities. We can get to operate the program that we've requested, some additional kind of flexibility under federal waiver authority for them to grant us to be able to have all of those flexibilities that we think we would need to be able to administer a more accurate program from the way that the current quality control process is run, but also continue to work with our staff and our clients to understand what information needs to be reported to the department, when, and how to do that in the most reliable way through our technology partnership and running Gateway, the integrated eligibility system, on things like changes. So when people move or have a job situation, that's going to trigger a change in circumstance that might not always, when all those other things are happening in your life, you might not think about also making some of those mandatory notification requirements to the department that could impact your benefits or impact ultimately your eligibility for those programs that, when our quality control routine goes throughout, could end up having an impact on the error rate.
One of the things that did come up along with the majority leader's office and others was this challenge, and obviously we're more on the medical side than the SNAP and other eligibility side, but brought up the significant potential penalties, and I just would like to make sure that we all, I don't know if you mind sending us whatever your status on that is. One of the understandings we were given was that during the public health emergency years and a little bit after, things that would have been an error in previous and now currently were waived, or certain requirements were waived, and therefore we had a zero error rate, which obviously wasn't true. But if you were able to waive certain types, and ours were all in those certain types, then the concern was a multi-$100-million potential penalty that would be taken from the program or taken from somewhere. So if you can give us a little follow-up on that, just so we can have confidence to tell our friends. Let's see, Chairman Taylor.
Thank you, Mr. Chairman. My concerns are in the same area. And one of the things I'm concerned about is the size of your staff. Is it adequate, and are they adequately trained? Do they know? And have you had turnover? I would say one of the highest areas that I get concerns from my constituents are in this department. And for example, your system, it's used by multi-agencies. They depend on it. And if that's where the error is, it's going to be in other areas besides what you do. Does that making sense? They use it for Medicaid and SNAP and things. So we need to make sure that it's correct. Is that where the issue is? And I'll follow up on that. Do you need a new system, something that can be used? Is this an investment the state needs to make?
So good questions. Again, we've been working in partnership on understanding what the department's vision is for the integrated eligibility system modernization. So just so everyone is aware.
Is that a new system, or is that just a continuation of what we had, the integrated eligibility system you mentioned?
Yeah, so Gateway today is an integrated eligibility system. For our customers, that means they have a one original place that when they make an application, they can kind of have a single point of contact to be able to apply for benefits from SNAP, TANF, Medicaid, CAPS, and WIC all in one kind of process. The WIC staff, for example, they do their work in Gateway, but they have a different eligibility staff. So the only eligibility determinations that DHS does is for TANF, SNAP, and Medicaid CHIP. So we don't do determinations, for example, for WIC and CAPS. They have eligibility staff at their in their agencies. We do, however, manage the system for the Department of Community Health in a contract that we don't have with the vendor. So we certainly,
Wait, who has the contract with the
the
vendor?
Department of Community Health,
But you guys are doing
we
the,
manage the day-to-day system
okay.
That's
operation.
where I'm at. I don't
That
want to be.
sounds like what you're getting at.
That's what I'm getting at.
Okay.
Where is the consistency? Where does the buck stop? And it stops with my constituents when they receive a notice to call and it's dated after the date of their appointment. And that's happened on a number of times. And it's something that, again, is it a system? Is it staffing? Is it other places? It doesn't matter to me where it is. It just needs to be fixed. That is something that is outstanding. We hear it. We all hear it. So that's a concern to me. And along with that, because changes, again, after COVID, we had issues. I'm hearing many of the local offices are not open Monday through Friday for constituents to go in and get service. Is that true? Do we have county offices or services that are not available anymore? And they used to be where they can't go in person. Everything had to be done online. And I represent a rural community. Some don't even have internet yet. They go to McDonald's in town when they can and try to log on, or to the public library. So there are issues that we have. Again, I'm looking for service to constituents that need these attachments. How do they get back in? How do we make sure that it is available for them? I guess part of that, I'll follow up with, what do you need to make it right?
Or-
That's
Or
where I'm
do
going.
Are they not open Monday? Are they not able to be open Monday through Friday for walk-in service?
So I think part of what we encounter in our DFAC staffing is the same thing that you guys see with lots of agencies, which is having a workforce available and having a client population that can be able to necessitate that investment of staffing, especially knowing kind of how challenging it can be to operate 159 locations. And so certainly, I know we continue to go through, or are going through an exercise right now of having additional conversations, as we do annually, about space utilization in our office. In terms of how we can again adjust staffing. We do have all counties open at least one day a week to make sure that we have a county presence. But I think part of that challenge continues to be just being able to have the resourcing and staff to be able to operate the types of situation that's available. We continue to have really good conversations on all of our resources. The governor's office has been very supportive. This General Assembly has certainly provided resources to the department that we use wisely to have the best stewardship to make sure that we can have those areas open as much as we can.
If I could follow up for a moment, to the $1,583,000 of recouped dollars, or did we got it back, or we got them to pay those services? Where will it show in a budget? Will I be able to see it? Or is it just we smacked the carriers and they came across and paid the bills?
Can you rephrase that question for me, please?
All right, I want to know where we can see the recovery of the $1,500,000. Is it going to show on a line item? You got it, or did you just?
I can have our budget and finance team get that information.
Yeah, I just wanted to see if it's, something we never got the dollars, we just got them to pay the claims and provide the service. Is that kind of what it is? I didn't know if you had to write a check for these.
No, this would be a reimbursement back to the agency.
After you've already written a check.
Yeah,
Correct.
you took care of it and they're getting
We
it
took care
back.
of it via a waiver
Okay.
and covered it and then reimbursed our waiver.
Okay, and we will be able to see that in the budget, so we know that that's been done. Are there more out there? Did we have to,
Yeah.
Are there more cases to be litigated? Is that what you're
yeah,
asking
that's
me?
fine. Have we got more out there we need to fight about?
Yes. And these results are, if this is just the nature of litigation in general, is even if I file the case today, it might be 2.5 years down the road before it gets resolved.
Can we charge them interest? Thank you. I have no more questions.
Representative Buckner.
Kind of along some of the same lines. I fear that particularly in the area of SNAP, we are hearing an awful lot about fraud and about error. And I think that gets confused. When you provide us with that information about the department goals, can you kind of highlight if there's some that was fraud and some that was error? So we'd know what kind of problem we really have?
All fraud will be an error, but not all errors are fraud. And so we certainly can talk to you about the strategies we're using to help drive the error rate down. parallel, we wrote last summer and were awarded a competitive grant by the USDA for fraud framework implementation grant. One of a few states to win with. And so we're also executing that fraud framework implementation grant, fully federally funded activities to further drive and enhance the fraud rate, which should spill over into reducing errors for the department as well. So it is not a singular issue. It certainly is something that we're attacking from all angles.
From the public perspective, they think that fraud means somebody's ripping us off or doing something terribly wrong versus an error being, oops, I didn't know to do that way. So do we have more fraud or more errors?
It depends, I guess, it's right. So we will always make a fraud referral to our Office of Inspector General, and the Benefit and Recovery Integrity Unit works specifically to recoup benefits from people who committed fraud in order to receive them. So our Office of Inspector General does have a very active fraud investigation unit that is actively recouping benefits and shutting down fraud, including referrals for prosecution and all of those things. Certainly can talk to you more about the types of activities that our fraud unit is looking at, right? What we are using as part of the fraud framework implementation grant is getting to the difference, right, for our customers. For example, if you have your household changes and somebody leaves your household unit and you don't report that they leave, but you continue receiving benefits for them, that would be an error. It certainly could be fraud, right? And so our eligibility staff and our Office of Inspector General have to evaluate all the cases. So we don't really have categories, right, where I can classify the types of errors that we see. The investigations always make that determination of fraud, but every referral for an investigation won't necessarily end up being fraudulent, right? It could be that it was inadvertent. Somebody fat fingered, let's say, their rent payment. And so instead of $500, they've put $5,000 and it just wasn't caught. Those types of things with the investments that we've been making in our analytics are things that we're able to now help flag for our customers, right? Hey, we're going to need to see verification because this doesn't match up to maybe what is expected to be, a monthly payment, for example, for shelter, we would call it.
Can I ask one quick follow-up? In the area of the responsibility of the Office of Child Welfare, where we're responsible for the food and the clothing and the shelter, especially of the foster children that we are taking care of as wards of the state. How do we measure up with our per diems compared to other states that we pay to the providers?
I don't know all of that information off of the top of my head, but generally it's a competition as far as per diems are with state to state on it with providers and states and the rates that they charge.
I've heard that with some of our providers that were on a list and taken off a list, that created an awful lot of conversation about the system doesn't always pay what other states pay. I also heard in those conversations that there are a lot of requirements in Georgia that are duplicative. If you are taking care of a child that is a foster child or if you are taking care of a child that's in the Department of Juvenile Justice. Has there been any effort to try to streamline some of the requirements we have for those providers so that they have less expenditures to get to do the work for the state, number one, and then number two, there is a huge requirement for a very large insurance coverage. Has there been anything or is there anything that the department can do to help them with that very large insurance responsibility?
Yes,
That's
so
so expensive.
a few things. One is we went through an exercise last summer of mapping our regulations against federal requirements and standards to make sure that we didn't have any unnecessary regulations. And so that process, basically I can tell you, we have a nexus of requirements. We're certainly going to continue to go through that based off of legislation that was passed this year. Again, always looking for any way that we can remove any type of unnecessary regulation. But most of our child care institution regulations are driven by federal requirements. On the issue of other states, the department has been undertaking a process with actuary of looking at a rate study. And so that process, I think, is something that looking at not just how we build our rates so that it's maybe grounded in a let's say predictive pathway of, hey, what should a rate be in the future versus today, and how do we budget sustainably for a rate? I was an appropriator for over 10 years. I can tell you having a sustainable pathway for funding is really key, right? So trying to understand what our rates should be and what the mix is something that we're, obviously actively looking for kind of what those pillars should be, right? To be able to have a conversation. We're not quite there yet, but continue to work on that piece. And then you asked about one more thing. Insurance. The commissioner has done a lot of work in that space. She's here. I don't know if she wants to talk about it, but we have certainly been looking at ways that we can adhere to the Department of Administrative Services requirements for contractual insurance on our vendors or on our providers in this case, and seeing if there's space that we can give. Those standards have always or historically been set by DOAS. What we've been doing recently is to be able to look at what makes the most sense for the risk and the liability and the insurance coverage for the providers to make competitive rates in our space and make sure that they can operate, while also making sure that they're grounded in something specific to the folks that do all the calculations from an actuarial standpoint of what that risk should be, right? So that we're not missing a process that otherwise would be necessary for any provider that's dealing with our most vulnerable population.
Right. I appreciate it. It's very hard for the nonprofits to pay that high insurance and then have to do 2 background checks and 2 fingerprintings, and all that adds up. So thank you.
Yeah, thank you.
And I'm glad you're doing another. Looks like this should be renamed to the rate committee.
It's got a lot on our plate, but thank you for your questions. This is the reason the study committee exists, for us to get this committee's questions answered. Chairman Hawkins.
This isn't a question. This is more of a commendation. I appreciate what you folks do. You have a great commissioner. I know Candace is working hard every day. When we looked at the SNAP program and looked at that more closely, we found that part of the error rate was actually the families, a lot of times single mothers that are working as hard as they can and taking care of 3, 4 kids, may have a kid go stay with grandma for a couple months. And, if there's a check back, that would be an error. And so sometimes, when we get so outbound on things like error rates, maybe we need to use a human factor sometime that's evaluated, because I know we're sitting at about 15 right now, and the federal government's threatening us with about $480 million. So I appreciate what you do, and I think we look forward to working with you to reduce that rate. Thank you.
Thanks, sir. Floor Leader Seabaugh.
Thank you, Chairman. I saw the commissioner get up to the podium. Do you want to say something?
Yeah, I can't help myself. About insurance, so what we're doing is we are going to, instead of imposing agency-specific policy limits on our providers that care for vulnerable children, we're going to instead cross-reference or really send them to DOAS guidelines. And in fact, that will be less than what we currently require on them. That's in their upcoming contract year, so which we just started, and we think that'll give some relief. It's not going to give them the relief that they need. They do need a legislative fix, and it is going to be an increasingly problematic crisis for them. They're paying tens of thousands of dollars in higher premiums every year, and sometimes these insurers will point to what they say are duplicative requirements that we or the state, multiple agencies impose on them. And we are in the process of trying to roll out some regulation changes to get rid of some of the red tape that's not related to child safety. And our board has to do that. But all that to say, they do need a legislative fix. And it's not going to be an easy one because it's going to be in the, Tort Claims Act section of the law. And it's going to involve a discussion of sovereign immunity. But that's something that if we don't get that kind of relief for them, then they're going to go out of business. And that's not a possible threat. That I just was notified yesterday of one of our biggest providers that cares for the most complex youth is probably going to close their doors at the end of this year. And part of their strain is insurance. For the related to the SNAP payment error rate, you mentioned the system, Chair Lady. One of the things that I recently noticed was that for the Georgia Gateway system, we went live, the state went live, not me, I wasn't at the agency, but the state went live with that integrated eligibility system for multiple agencies to use, but for customers to have a one-stop shop to apply in 2017. And what you can see in the federal data for our SNAP payment error rate is that the year where we're not using Georgia Gateway, it's not a knock on anybody. These are just the facts. The year that we're not using it, we're using the prior system. Our payment error rate for SNAP is between 6 and 7%. The next year when we go live, it goes up to between 9 and 10%, according to federal records. And then it's been going up ever since, except for the years where we didn't have to report because of the public health emergency. They gave states some leeway. And then for federal fiscal year 2023, we happened to have a payment error rate that was between 8 and 9%. But at that time, the new constraint was that the Biden administration wanted us to roll out a policy change to improve our timeliness of processing applications. That is almost, an immediate inverse effect on the quality of the work that we're doing. And I'm not going to bore you with the specifics, but what happened is you saw that really dramatic jump to where we're in the 15% range. We've rolled back that Biden era policy change. We expect another reduction in the payment error rate plus the other things that we're doing. But at the end of the day, my counterparts and I, when we see each other at conferences, we just wonder whether this is truly feasible at the rate that it's currently set. We're going to do everything in our power to get there, but it is incredibly difficult for anyone to reach and sustain at under 6%.
Thank you. So my question was around the child welfare case managers. Do you have a plethora of case managers and a waiting list to come on board? So, and I say that in jest. So I don't know what they make. It's not enough, whatever it is. But does the private sector take a lot of, is there a lot of turnover with case workers?
There is, and it's a tough job because you're dealing with children, families, you're dealing with court, you're dealing with law enforcement. I have even had conversations with caseworkers and they were somewhat excited about this because they were trying to find somebody going to like a known, crack house on it. So it's a stressful job. There's a lot of things to do. And the amount of administrative work piled on top, that was the point I was making. They have a day-to-day life of managing a certain amount of children that are placed in their care, custody, and control. Well, why are we trying to make it harder by making them have to do paperwork after how many hours a day they're working at that?
So I said that because I know that's a problem. I know that the turnover is because the private sector is paying more money. So once they get some experience, they're going to the private sector. Because I know several of these case managers. So I guess my question, and that's what this committee's for. How do we address that issue to try to retain good case workers, try to get them to come on board and stay and not overload them with, I don't know what their caseload should be, but I know that they're probably overloaded from what it should be. So I would love to work with the department on how we keep a pipeline of caseworkers coming into the state to help us with this issue. I think next year with our new governor being a product of the foster care system, he's going to be very excited about trying to fix some of these issues. So I hope that the department will be open and let us help me help you. And I guess what I'm saying, because what you do is extremely important. And the caseworkers truly affect how these kids are going to turn out as adults. And we don't want them to be stressed, and we want to give them the tools they need to do the job, and we want them to stay working. So I say that, so use this committee as a resource to let us help you figure out a solution to the caseworker problem.
Yeah, one of the things that for sure I'll note real quick is the more that we can strategically and intentionally take care of the medical needs and make sure that our children in foster care have clinical community-based supports that will help keep them in foster homes, keep them to be able to be cared for in the community with all of the things they need from a medical perspective, it would certainly make a lot of the friction that our caseworkers feel even better. So anything that we can do on the health aspect of medical and dental needs certainly is a relief to some of the tension that our caseworkers feel right now dealing with the complex care requirements of children in foster care.
Thank you. And that's one of those things where at some point you need to give this committee kind of some examples of the kind of things that might help. I know you'd like to work through your different departments and your fellow departments, but at the same time, that is our role in a lot of this. And since we're focused on the healthcare side, if that is a major friction point for your staff and longevity and retention and everything, then certainly we'd love to work on that. Buckner.
Thank you. All of this just brought to mind another situation when we talk about taking care of the healthcare. There has been conversation for a number of years to change the computer system so that all of the state agencies that touch the foster child would have access and shared information. So I know representing part of Columbus, we sometimes get foster children from Savannah. The child gets there before any information about the child. And for example, we can't put them in school because we don't get that for a month. The schools don't share that information timely, or we may not have the information that the child's insulin dependent diabetic and they get into a medical emergency that would be unnecessary. So what is happening with improving Shines or developing something other than Shines or having some kind of shared system between all the agencies that touch that foster child so that the records can get where they need to go in a more timely manner?
I would say we have big plans, I think, for what that could be. And maybe worthy of a different kind of discussion so we can give it all the context it needs. It certainly is something that the commissioner has been very vocal about making sure that we have all of the aspects, things like just continuous or complete medical records is something that our agency struggles to get from our school systems, even from all of the folks that might have interacted with the child before they come into foster care. And so I think that certainly is, again, something that I think is worthy of maybe having a different follow-up discussion specifically to focus on kind of where we have some opportunities.
I sure hope we do and do it quickly.
Thank you.
Thank you very much for your presentation today. Thank you, Commissioner. And we will move along. Thank you. Now we go to the Office of the Commissioner of Insurance, Mr. Rawson and Ms. Gardner. Y'all can come on up, and if you want the podium or the table, let me know.
Thank you, Mr. Chairman and members of the committee. My name is Bryce Rawson. I'm the Director of Legislative Affairs for the Georgia Insurance Commissioner's Office. Today behind me, I have Ms. Cheryl Gardner. She is the Executive Director over Georgia Access, which is the newest division of our agency. Of course, being the insurance commissioner's office, we also house the state fire marshal's office. Health insurance is just one portion of our agency, but it is a big portion. Today, we were invited to talk about implementation of a number of bills that were brought to our agency and passed by the General Assembly. We wanted to make sure that we focused on what bills have been the most effective and most transformative in Georgia. So a couple of those bills we're going to focus on today. Senate Bill 106 of 2019, that also known as the Patients First Act. That bill allowed us to pursue a 1332 state innovation waiver. And the second bill we're going to talk about is Senate Bill 65 of 2023, which authorized Georgia to go ahead and pursue implementing a state-based health insurance exchange. And with that, I'd like to invite Cheryl to talk about Georgia Access.
Thank you both for being here. Thank you for updating us on Georgia Access and kind of explaining to the committee what that portion's role is in insurance.
Perfect. Thank you so much. Again, my name is Cheryl Gardner, and I'm the Executive Director of Georgia Access. Is that a little bit better?
That's a lot better.
Great. A little bit of history here. Well, I think it's fair if we start with where we were. So in 2019, we had only about 1/3 enrollees in the federal exchange. Every state, you'll recall, under the Affordable Care Act, had to establish a state-based exchange. And for states that either could not or would not establish an exchange, they deferred to the federal exchange. On the federal exchange, we only had about 1/3 folks. And at the time, there were about 1.3 million uninsured people in Georgia. That was obviously unacceptable. Lots of them we knew were eligible for the program, but for whatever reason, just were not signing up. Some of them, as we've surveyed over the years, we found that they were unaware that they were eligible. There was distrust. They had had a bad experience. For whatever reason, they just were not signing up. So to your credit, you passed the Patients First Act, which enabled a couple of things. And one of those was a 1332 waiver. My colleague will talk more about that later. But the other bill actually allowed the state of Georgia to establish a state-based exchange. We did kind of a hybrid launch in 2024. The state handled everything except for the technology and the contact center. We did all the plan management, the regulation, the outreach. And then for plan year 2025, that's when we were all in. We did all the technology ourselves. We ran the contact center, including the contact center is quite large. It may interest you to know that Georgia actually has the second largest state-based exchange in the country, right after California. So Georgia's population on this is quite large. So what did this look like? Open enrollment for 2025, we actually are pretty proud of our achievements. We did increase the number of insured Georgians. We brought some revenue back into the state, and you may not understand, I don't know that anyone has told you, when you're using the federal exchange, you don't get to use it at no charge. There's a hidden tax there that goes against the carriers, and that, of course, gets added back into the price of premiums. So one way or the other, that charge is going to go back to your constituents. When the federal government was charging that user fee went right back to CMS. We charge a user fee now. The user fee stays here in Georgia, and it not only funds the exchange, it also helps fund the reinsurance program that Bryce will talk more about later. So that was a way to actually keep those funds inside the state. We also incented private sector investment and cooperation. In 2019, the federal exchange figured out, gosh, if we let some private sector folks help us out with this, we'll make this much easier for the private sector to enable enrollment. And they started using what's called enhanced direct enrollment. That means that if you're going through the federal exchange, you could use either the federal exchange's front door, which is healthcare.gov, or you could go through any number of private sector partners. It may interest you to know that today, only about 30% of the enrollees in the federal exchange go through healthcare.gov. The other 70% go through the private sector partners. They get better service that way. They just like it better. You could interview them and ask, and they could tell you why, but for whatever reason, they like that better. When we got ready to transition, we had two choices. We thought we can either tell all these people you can quit using the private sector partner you like, and everybody will have to go through the state's front door, or we can adopt a no wrong door approach and continue to use these private sector partners. And that's what we decided to do. We were the first state-based exchange to do that. Normally, if you don't make that decision, you will lose probably 10 to 15% through attrition. People just get frustrated. They were already enrolled with somebody they liked. You made them change. They're mad. They're not going to go through that trouble again. We actually grew our enrollment. We did not lose any through attrition. So we were very happy about that. We offer 18 plans. That's, sorry, I should say 18 carriers. And that's for both qualified health plans and standalone dental plans. Our first year, at the end of open enrollment for 2025, we had 1.5 million enrollees. And we got there for a couple reasons. Of course, there were enhanced subsidies, COVID era subsidies at the time that were more generous. So that was part of the growth. The other big part of the growth was also that we actually went out into the communities. We instituted a community partners program where we were able to give folks a lot of information about how to get enrolled. We were very, very active with agents all over the state. About 80% of all of our consumers enroll with the assistance of an agent. Georgia has historically been a big agent state. And so if you look at our numbers, that's 1.5 million enrollees. Almost 250,000 folks had never previously enrolled in Georgia Access or the FFE before. We had more than 17,000. Actually, by the end of that year, we had about 19,000 agents who were certified and actively selling Georgia Access on Georgia Access. And again, 80% of our consumers use an agent to enroll. What are we looking at today? We still have, between the 9 insurance companies offering QHPs and the 8 insurance companies offering standalone dental plans, we have a very, very competitive market. This is my 4th state exchange that I've worked for, and by far my most competitive market I've ever worked in. We still have over 900,000 enrollees. So if you looked at all the estimates of how many we were going to lose, the estimate was that we would get down to about 600,000 enrollees for 2026. That did not materialize. We're still very close to 1 million, and we still have over 17,000 agents actively selling. We do have a very specific population that we enroll. Per the ACA, it's only those between 100 and 400 FPL, federal poverty level, who qualify for coverage on the exchange, or I should say qualify for subsidies on the exchange. You can make more than 400,000 FPL, you can make less than that, and you can enroll, but you cannot get a subsidy unless you're between 100 and 400 FPL. I also think it's, when we're talking about the folks who rolled off the exchange, more than 100,000 of them rolled off because the federal poverty level changes every year. And it went up, and we had about 130,000 who were no longer eligible, who were then eligible for other programs in the state, but just not ours according to a federal law. And with that, I will turn some time over to my colleague to talk about reinsurance.
Thank you, Cheryl. So move on to reinsurance. That was one of the primary goals of the 2019 Patients First Act. So of course you guys passed that bill in 2019 that allowed us to pursue the 1332 state innovation waiver. And what 1332 waivers allow us to do is to pursue innovative strategies that provide residents with access to high quality, affordable coverage. It doesn't come, of course, without its guardrails. So there are 4 primary guardrails that we have to pay attention to. The results of it, they have to be comprehensive. It can't have has to have more benefits or equal to than what is currently being offered. It has to cover the same number of people or greater. It has to be affordable as well. Again, that is the same price, or less. And then it has to be federally deficit neutral. So we cannot add anything to the federal deficit. So the reinsurance program itself, it is designed to expand coverage options for consumers and reduce their monthly premiums by incentivizing insurers to participate in our state marketplace. Usually insurance companies, when you get into areas of our state, as I'll show y'all on some maps later, there are certain areas that they just don't want to participate in, that they are typically seen as higher risk. And so by getting insurance companies to go into those parts of the state that are seen as higher risk, we not only are we allowing consumers to get a better price on their coverage, we're also allowing them to have more options, which is also another desire of consumers in this market. Insurance is typically a business about predictability. And when insurance companies can better predict what their costs will be by stabilizing, the cost of insurance and the utilization as best as we can, the idea is for them to pass the savings back on to their consumers. And I also do want to note that the reinsurance program, it only covers individual plans, that is both on and off the exchange. But most of those, about 97% of them, are on the exchange. So in front of you, you're going to see a map of Georgia. This is reinsurance in 2026. We're going to talk a little bit about how that program works and what it looks like today. So moving through that chart, first and foremost, on the right side, you're going to see two attachment points, one called the lower bound, one called the upper bound. How the reinsurance programs works is that costs of medical claims that fall within those two bounds, between that $35,000 on the lower side and $500,000 on the higher side, the reinsurance program covers a portion of the claim that falls within those bounds. So if you'll take a look at the map of Georgia on the left side, you're going to see three colors on the counties. Gray represents a tier 1 county, blue represents a tier 2 county, and green represents a tier 3 county. And what your tier determines, this is the third row on that column, or on the chart, is what the coinsurance rate in your county will be, which is how much the reinsurance program will cover that is within those bounds. Those counties, they were decided during our initial application period when we were looking at establishing this reinsurance program. We took a look at how many insurance companies were offering coverage throughout the counties, and this is the result that we did end up with. In tier 1 counties, the program covers about 15% of the cost within those bounds. Tier 2, that number is 45%, and tier 3 is 80%. As a result of the program, consumers that are in tier 1 counties are saving about 5 to 10% on their premiums. Tier 2 is 10 to 20%, and tier 3 is 20 to 30%. So if we did not have the reinsurance program today, then it's safe to say your cost would go up about that much depending on where you live. But let's take a look at reinsurance in action just to really drive the nail home on how this program works. So let's take an imaginary constituent in a random place. Let's say Bob Smith lives in Augusta, Georgia, right? So Bob, he is playing soccer. He likes to play recreational soccer. Shout out to the World Cup fans that are here today. But unfortunately, he gets hurt and he's sent to the hospital with a broken leg. I'm sure he gets world-class care by one of our physicians over in Augusta. After treatment, the provider sends Bob Insurance Company a bill totaling $106,000. Please keep in mind these are arbitrary numbers, and this is just a simplistic example just to show how it works. Bob pays his max out of pocket according to his insurance policy. That number is $6,000, meaning the insurance company is on the hook for the remaining about $100,000. The insurance company, they will then send us this claim at the end of the month, let us know this is what their expenditure was for Bob's injury. And what we do is now that we take a look at that amount and compare it to where he lives. So since the program only covers the amount that's between $35,000 and $500,000, the eligible amount is $65,000. Since Bob lives in Richmond County, that is a tier 1 according to the map on right here. That results in a 15% coinsurance rate. So we do the math. You take 15% of $65,000. That's $9,750. And that is the amount that the insurance company is reimbursed once the reinsurance program has gone into effect. What the reinsurance program has done, as I mentioned earlier, has increased carrier participation in the state of Georgia. You're going to see three maps on the bottom of this slide. Red, there's a little key on the right side. Red means there's only one insurance carrier in that county. Yellow means there's between 2 and 4 carriers. Light green is between 5 and 8, and dark green is 9 or more. As you can see in 2018, there was a clear disparity in Georgia. Most counties in Georgia only had one insurance carrier offering coverage. That doesn't mean plans. That just means there's only one company XYZ. They may offer 3 plans, but there's only one company. You don't have a whole lot of options, right? So you can see over the course of time, 2018, we didn't have much, but in 2026, it's a very different story. In 2026, there's no longer a single county that only has one carrier option. Now, most counties, in fact, have 5 or more. So there has been a tremendous growth. We have 2022 map in the middle there. That is the first year of implementation of the reinsurance program. So we already saw tremendous growth from years past. Of course, in 2018, we only had 4 health insurance carriers offering coverage on the marketplace. That explains why there was that disparity. And yeah, so there has been clearly a tremendous growth because of the reinsurance program. And that's the feedback that we've gotten from the insurance carriers as well. Now, the big question that I'm sure you all want to know, where does the money come from? Who's paying for this? There are 3 primary funding sources. First is going to be the federal government. The federal government, they have a confidential formula. They have not shared that with the state of Georgia or any other states that operates a reinsurance program, if any. What we do know are some factors that are included in that. So that is the number of enrollees, that is the cost of the plan, that is the number of claims that are involved as well. So we've seen that the number has shifted that we get from the federal government based on how those shift. But again, we don't know what the exact funding formula is. So we rely on projections to get state funds, which I'll get into here in just a minute. In fiscal year 2026, we received just over $1 billion from the federal government to fund the reinsurance program. So this is over $1 billion program. The second avenue of funding is user fees. So user fees, they are a cost that is paid by insurance companies to sell their plans that is on the Georgia marketplace. As Cheryl did mention earlier, that there's a cost that you pay to operate on the federal exchange that would go to CMS. That's the user fee. We are retaining that here in Georgia and spending that on Georgia Access and the reinsurance program in order to better use those funds rather than sending them out of state. The current user fee is set at 3.25%, which generated about $84 million this year towards that, and most of which has been applied towards the reinsurance program to cover some of those costs. Lastly, is state appropriations. Each year we come to the General Assembly. Those of you who have been, who are on the appropriations committees have certainly seen some of these presentation slides before. But we come to you guys and ask for appropriations. And thanks to lower claims than anticipated, we're very glad that we were able to return all of those funds this year. We did not have to use a single state dollar towards a reinsurance program that was allocated, so we did send that amount back. The original amount that was appropriated to us was just over $145 million. And again, that was returned. I know that we threw a lot of information at you guys very quickly, but we would be happy to answer any questions you all may have about Georgia Access or the reinsurance program or any other matters as you see fit.
All right, thank you. I think that was one of the more impressive graphs to see the difference that the program was making to make it. I know that's the kind of increase in carriers we were hoping for with some of our recent lawsuit and insurance reform, is that they would also come into where we saw dwindling numbers of companies willing to even sell insurance. And now that seems to be improving. I'm assuming that competition is going to drive at least to the lowest rate possible the premiums, but they're still not as low as we'd like. Chairman Taylor.
Thank you, Mr. Chairman. I appreciate this report. It's great information. I do have a couple questions. I'll start with the reinsurance. Is it per year? Is it per claim, per incident? When you get that deduction when you file it, is it?
So insurance companies, they send us usually at the end of the month. Of course, I gave you guys one example. We're getting thousands of those every month that we're getting from the companies.
I just didn't know per per person that had a claim. If they had a claim in January and it went over, they would send it in when they process and pay it, I guess. And if the person has another claim, it would be another filing.
If it falls within the bounds, yes, because not every claim is going to fall into it, right? Because it has that $35,000 attachment point. Going to urgent care or whatever it may be, those aren't going to fall in there.
And to follow up, I know we've started the new program a couple of years ago with ICRAs. Have you seen where that has helped lower the uninsured? Where, again, I know several folks that use the access, and if it doesn't fit into one, they go into another. And employers have joined in on these individual policies. Is that something you think is improving the coverage for our citizens?
Let's say what ICRA stands for first.
Okay, it's
Individual Coverage Health Reimbursement Account. Is that right?
Yes.
Arrangement.
Yeah.
That's what you're asking about, individual
Yes.
coverage for a.
Yeah.
Okay.
I'll have Cheryl come and talk about the latest initiative we've done related to that. It's called Georgia Access for Business.
Okay.
So we're actually big fans of ICRAs. This is one of those things that it doesn't matter what side of the aisle you're from, it seems to make sense. We have employers who we've talked to over the years who have said, hey, I would like to offer my employees something, but I'm a startup, right? I don't offer them anything now, but I would like to offer them something. This enables employers to take, $300, $500, $700 and offer it tax advantaged, and that really matters, offer it to that employee. Now, it's an arrangement because it's owned by the employer, but the coverage choice is made by the employee. In other words, the employer is out of the business of selecting coverage for the employee. And any of you who have worked as a CFO or an HR representative or who have owned a small business, you know that is, you're there to make widgets. You're there to do the thing you do. You're not there to figure out which employee plan won't necessarily work for all employees, right? That's such a hassle. This is something that was created at the federal level. The state did not create it. However, we recognize that there's absolutely a need for it. So earlier this year, we launched Georgia Access for Business. We started training agents, and we will later on this year begin. There's a real ramp up to it. So in about September, we'll start having individuals be covered. Now, this Georgia Access, that's the one that's part of the Affordable Care Act. And then Georgia Access for Business is not part of that, but it's a program that we're doing anyway, just because there's such a demand for it. Now, we also think that your question was about, can this lower the uninsured rate? 70% of those, I saw this stat the other day, 70% of those who enroll in an ICRA plan were previously I shouldn't say it's the enrollees, 70% of businesses who offer it previously did not offer coverage. And so what we're talking about are typically those startup companies, right? Maybe it's a landscaping company, maybe it's a tech company. And we think that there's a lot of promise to this as we go along, including if you have two employers and each of them offer a contribution to your ICRA. Say you drive for Uber and Lyft, and Uber offers $200 and Lyft offers $300. We think it makes sense to combine those contributions so that they can be toward the purchase of single coverage.
Thank you. I hear the same thing, that it is working very well. One more question, if I might.
Certainly. The
The funds that you're recovering, like from the health insurance carriers, does that go to the department or to general funds?
So that goes to, I don't want to say this wrong, the department. It doesn't go into general funds. User fees by federal law can only be used for very specific purposes. One of those being the 1332 waiver and the insurance, the state-based exchange.
Well, you have made great improvements. Maybe those funds help to be able to do it because it is working very well.
Thank you very much.
Chairman Leverett.
Thank you, Mr. Chairman. Just a couple quick questions to make sure I understand sort of on a foundational level. So the waiver that you've requested from the federal government allows you to sort of offer this program to insurance companies that desire to participate. Do they have to sort of make a filing with you to elect to participate in some way?
For the reinsurance program.
Yes.
Yeah, so they file the claims is the best way to say it. They report their expenditures to us, and they have the opportunity to partake in the program.
So if they offer health insurance in the state, in the individual market, they automatically can submit for the reinsurance, what effectively seems to me to be a sort of a reimbursement of a portion of their exposure on the claim.
Correct.
Okay.
Yes.
So they don't have to file an election with you or covenant to do certain things other than just, we want to write health insurance in your state for individuals.
Correct. And that's one of the driving factors of bringing these companies in, right? We only had 4 companies writing coverage in 2018, and then now we're up to the highest we got was 11. We've had a couple of those drop off, but they've dropped off on a national scale, not just in our state. But we still retain a great majority of them. I think we're at 9 today.
And the map that the chairman was referring to, that's carriers, not necessarily plans.
Correct.
That are available.
Correct. Each carrier is most likely offering multiple plans in that district. Probably a bronze, silver, gold medal style plan.
And then you have to do these actuarial and economic analyses, I guess, and submit them to someone, a federal agency, to justify the continued existence of the program.
Correct.
Okay. And the chart that you had that kind of shows the map of the state and the different tiers, are those tiers determined by some federal designation, or do you determine the tiers?
So those were determined when we first applied for the reinsurance program. So if you take a look at this map of 2018 that I have, it's going to be on page 12 of your handout. You can see really where there is a deficit of carriers offering coverage. Of course, the more accurate map will be take a look at 2021, which I don't have on the screen for you here today. I can certainly provide that. But it'll show you where are insurance companies currently participating and where are they not participating. And so the reinsurance program focuses really on the areas of the state where there was no coverage, where there was a lack of available, affordable coverage for insurance companies or for consumers.
So the map you've got on page 10 is the current tier structure. And so, for example, my county is one of the tier 1 areas. I guess it's area 2, it looks like. So does that mean, since the co-insurance rate is less, does that mean there was more availability of insurance, so it wasn't a need to offer quite as high a co-insurance rate?
That you have the general idea correct there, sir. Yes, but it is really based on the number of insurance companies that were offering coverage at that point in time.
Okay. So in other words, the tier 3s tended not to have as much availability of carriers, whereas the tier 1s did.
Correct.
At least conceptually, in theory.
Yes.
Okay. That is a good question. Does that get re-updated since things may have changed? Well, obviously everybody has 4 or more now or something, but
at least for the reinsurance program, because
it's set by whatever it was when you needed it. It's set.
We can redo it every year if need be, I'm told. I'm sure that would we would have to file that with the federal government and go and probably redo those actuarial justifications.
Be careful, it could get worse.
Could be.
Theoretically.
And one final question. So you mentioned the appropriation that was fully returned. So I was just curious, and this may be a detail that your accounting really can't answer, but we receive, it looks like that's $1 billion something from the federal government to fund it. And then you also got the money in user fees. So did you, from those funds, you were able to make all the reinsurance payments you needed to, and you didn't have to touch the 145, or did that at the end of the year, you had that left over and were able to return it?
So we use the funds in order. Of course, we have our first payments really happen because the federal government has a different fiscal year than we do. So our first payments really come out in about November, October-ish. But we use federal dollars first. Then we use whatever we can, user fees, to offset the cost that is remaining. And if we have to, we dip into the state budget, that appropriation that you guys give to us. And we have a projections formula. Of course, like I mentioned, we don't have the full formula from the federal government that says, hey, this counts for this part, this counts for that, to get the funding, right? We really just get what we get in October from the federal government. And then once we receive that, then we know, okay, we can update what the numbers are going to be, which is good for us because in time for session, we can come back and say, hey, this is about what we expect it to be. Of course, we have to keep in mind, we get that money in October, but we still have October, November, December worth of claims experience that we have to keep in mind. So we try to come to you guys with the best estimate we can of how much this amount is going to cost and what we can return to the state.
Is the system or program designed to operate exclusively or primarily off the federal funding amount and the user fees, or is that just the happy accident that happened this last year?
It is purposeful. Let's put it that way.
Okay.
So the chart that I have on page 10 that shows the tiers, if you look at the lower bound and upper bound, that's where we have a little bit of control over what claims are going to be involved, right? Because the amount of claims is likely going to be the biggest factor that is involved in calculating how much we get from the federal government. So if we change those bounds, right, it decreases the amount of claims that are filed or that would fall in there, and can therefore change how much or lower or increase, depending on how we do it, the amount of reinsurance claims.
And so the lower bound and upper bound apply across all three tiers.
Correct.
I understand. And those are numbers that are set by you as part of your application for the waiver.
Yes, and,
Okay.
and we can change those for the upcoming year. I believe that number is changing. I don't have that number on hand. I think the lower bound is going up by maybe $1,000 or $2,000.
So that the upper bound and the lower bound can change from year to year.
That is my understanding.
Do you have to get the waiver each year, or is that because of the initial application you made for the waiver contemplated those would
We
change?
don't need to get the whole waiver each year. We just need to communicate, what our intentions are. Of course, we have to go to the federal government and say, hey, this is what we're planning to do, but we can change a lot of facets. of it,
Okay.
yeah.
All right. Thank you very much. I appreciate it. Thank you, Mr. Chairman.
Representative Buckner.
Changing channels just a little. It was about last year, it was August of last year, that the insurance commissioner announced that there would be $20 million in fines for non-compliance on mental health parity. How much has been collected?
So a lot of those are still in the process of going through, because we initially issued those fines, right? But then the companies, they're going to negotiate.
wanna
with us.
pay
They're
'em.
going to talk about it, right? That not just with our agency, that happens with any agency that can issue fines against companies. So those are still in process right now. So we are waiting for some of those. It's as you can imagine, a long legal battle.
Okay. This is a change in channels again. We were just talking about foster care and that they have a huge requirement for insurance. Is there a way for the department to help them come together and develop a group plan to cover all of the state agencies that provide care to the wards of the state and have coverage as a group, self-insured group that the insurance department could help develop?
The issue with the foster care system and early learning care centers as well. I just took a call on that yesterday from a concerned constituent who owns one of these types of facilities, who continues to say, hey, we're having trouble not only getting insurance, but the
Right.
companies that will offer insurance, it's unaffordable. They can't sustain it. And a lot of them are talking about going out of business. It's an ongoing issue that we are having active discussions with a lot of the associations that are involved in these industries, trying to figure out what's going on. If you or I could figure that out in conversation today, we wouldn't be sitting here. We'd probably be sipping drinks on a yacht somewhere.
That'd be
but it
nice.
is-
Yes, Mr. Chairman. I wish there were a way that we could do something to try to help them.
We stand ready to assist as best as we can, right? We've had conversations with a lot of these companies that used to offer this sort of coverage that no longer don't. And a lot of the answers that we're getting, it's another tough fight. It's in the realm of like the tort space. That's what a lot of them are saying. They're concerned about the liability that they have as a part of these facilities. And so some of them are hesitant to come back or expand their current offerings of coverage.
I'm not sure it's tort this time because of the fact that a lot of these companies have been in business for many, many years and had no issues. It's just the insurance companies going up and up on their rates.
I'm just relaying the message here that we've had in conversation with these companies. So.
Chairman Hawkins.
Pertaining to the MLR rate, is that evaluated on the federal level, or are you tasked with evaluating the medical loss ratio of these companies?
I believe that is the federal government's responsibility.
Okay. Yeah, I figured it probably would be, but they watch things so closely up there. I wonder if we need to sort of look at it ourselves too. Yeah, thank you.
Well, thank you, and thank you for your presentation. Thank you for you and your commissioner's work, and appreciate you being here today, educating us. I'm sure over the course of our next several meetings, we may have additional questions and clarification. Thank you for your willingness to meet with us.
We'd be happy to come, and thank you for your time, Mr. Chairman and members of the committee.
Thank you. All right, we have on our agenda the Georgia Composite Medical Board. If you want to do this table or the podium.
Gonna run the presentation.
All right.
For me. She's pretty quick.
Please come on down. You take your time. Although we will be getting at some position retention and recruitment or workforce at our next meeting as well. But certainly, please give us an overview today of and proceed. Just introduce yourself for everybody watching.
All right, I'm Jason Jones. I'm the Executive Director for the Georgia Composite Medical Board. And we thank you for having us out to give you a rundown on our current status. And I'm going to go over kind of what we do and what we've done with what you've provided us previously, and then what we probably need in the future with what we're going through now. So on slide 2, you'll see the agenda. You'll just see that we don't just do licensing. We do a multifaceted of services under our belt, which is licensing, investigations, compliance, legal. There's a lot of hats that we wear, not just licensing. So I want to make sure that we go over that. And a lot of my presentation is going to be on that. So what we've done with the legislative funding that we did get from you all when I first got on and first started, and then years past, is we faster licensing and case resolution times. We've identified scope of practice violations, dangerous or unlicensed providers removed from practice faster. So with that funding, we've been able to do this and make sure that we're achieving our mission. And then we are proactively inspecting Georgia's medical facilities or offices, I should say, with that. So our mission is to protect the Georgia citizens and make sure that we are licensing proper physicians and other medical members, and the objective enforcement of the Medical Practice Act. So with that, we license, and then we regulate, and then we also educate the profession. So this slide 4 will show you kind of the makeup of the Georgia Composite Medical Board, our authority. We have 14 board members, 52 total staff now. Thanks to you all, we were able to get that funding to, when I first started, we were 38. Now we're at 52. So I think we're doing much better with the staff. And then our core divisions is licensing, compliance, investigations, legal, operations, and finance. So we have all that going on in our space. So slide 5, this is the current licensing numbers. So we're at close to 72,597 licensees. That's grown since I did this chart. Since fiscal year 24, we've grown by 12,500 or so licensees, and that's across the whole 12 professions that we regulate and license. And then we also don't license APRNs, but we approve protocol agreements between them and physicians, and that's about 25, close to 26,000 protocols active that we have in the system right now. So slide 6, that's going to give you what the modernization of our licensing system did. That funding that you provided us in 25 was we were able to modernize our licensing. So if you notice the physician license, that's a 67% improvement. So prior to that system, it was almost 150 days to get a license. Now it's around 50 days to get a license, and we're hoping to keep chopping away at that. APR and protocol agreements was 120 days. Now it's about 20 days. We can actually approve those on the same day now, as long as everything is sent in and the requirements are there and signatures. That's about an 83% improvement. Physician's assistants, so about 60 days prior to the system. Now it's about 40 or 39 days. And the reason for that is we don't administratively approve those. Those go to the board, and they have to review each of those before they're approved. So that's about a 34% improvement. And then respiratory care professionals, again, 44% improvement. So as you see with the new system in licensing, we've improved our licensing times, and we'll continue to work on that through reviews and making sure that we're using our personnel correctly. So, and that's just been within a year. So July 2025 was when we implemented that. So that's been a year, and we're showing the improvements. So with those improvements also comes growth. So on slide 7, you'll see just active physicians alone. That's almost a 40% license gain that we've had. So that's workload going to our staff to do this. And so that costs them time and them hours to do this. So on this slide, you'll also see the amount of hours it takes to do the calls, the emails, the license review. All this stuff adds up for our license techs and compliance techs to do. So if they did everything that they're tasked with, it'd be a 19-hour day. So, they can only work 8 hours, but everything they're needing to do will be a 19-hour day, if that makes sense. Our calls alone, on average, 20 minutes each, already exceed the 8-hour day per staff because we get about 2,000, 3,000 calls a week. So that takes time. We got a lot of missed calls because we just don't have the resources to do that. So slide 8. This will just show our compliance section. So this is the reorganization of our compliance section. We did stand up a inspections unit to kind of help with compliance, because when I first took over, I noticed that we didn't have an inspections unit. How are we going to be able to go out and proactively address some of these compliance issues without somebody that goes physically out there? We do have criminal investigators who go out on egregious acts to investigate, but we were missing that piece of inspection. So we were able to stand up an inspections unit. Right now it's 2 inspectors. We're going to hire a 3rd inspector next month using our retained funds. So we're using resources that we normally don't use in order to create these positions to address the need of inspections. These inspections are going to help us with our compliance matters to make sure that we're addressing patient safety issues is our main goal. So slide 9 will show you our compliance case volume. So compliance and investigations are different, so we keep track of those differently. These compliance cases, as you can see, fiscal year 24 was 1,392. Fiscal year 25 was 2,376. Projected fiscal year 2026 is 2,944. And then projected based on the growth that we've seen, fiscal year 2027 is still going to exceed that at 3,649. It could be give or take some, but we see that progression of compliance cases going up. And it's not necessarily that there's more misconduct. It's just our operations are getting better and we're identifying more. And with our public outreach, we're getting more coming in because people understand what we do and how we can help in patient matters. So right now we have 5 compliance specialists that handle those 2,376 cases that come in. And that's a lot for them to do. So we have to triage those. So we're going by patient care, patient harm first, and then we're triaging how best to address those for patient care. And our compliance inspectors, they cover a lot of medical offices that are around the state. We have 25,000 different medical offices that they can inspect, but we just don't have the resources to do that. Slide 10, we'll carry on from the other statistics. So these statistics are more of the complaints that we get coming in. Clinical privileges, quality of care, unprofessional conduct, telemedicine. These are the things that our compliance specialists look at and investigate. So with that fiscal year 2026 number, you'll see it's highlighted. With our system integration and our new movement, I wasn't able to get accurate numbers for that. So I want to wait until I get accurate numbers to share with you. But the numbers that I do have grown tremendously from the fiscal year 2025. So we're looking at over 3,000 or so cases from the same case types that that they'll be, they worked in 26, 27, I'm sure will increase as well. But so these are more, our compliance section does more of the gathering of information from the medical facilities, from the doctors, from the patients. So they don't go out. They stay in the office and they do this, collect this data, provide it to the medical directors or the peer reviewers for them to do their assessment. And then it goes back to the board to make a decision whether it met standard or not. So that's what our compliance specialists do for patient care. And then slide 11. I think we'll just skip over that one. That's just more statistics on investigations. I don't think we need to go over too much. So slide 12, that's the current state case statistics for investigations. So these are our post-certified investigators that go out and deal with unprofessional conduct, impairment, criminal conviction, sexual misconduct, overprescribing, those type of complaints that come in against practitioners. So in fiscal year 2025, there were 448 total investigations opened. As you can see, quality of care was one of the top, and then overprescribing was one of the top complaints that come in. Let's see. In these cases require more case involvement because it's more interviews of witnesses, interviews of complainants and victims, and gathering of information, surveillance. They do all that stuff to make sure they're getting everything they need. Slide 13, that's going to be fiscal year 2026 current statistics. So as of now, we have about 832 cases and inspections currently in backlog awaiting assignment. So with our new process of public outreach and things, we're getting more of this coming in as well for folks knowing what we do. So that's 832 complaints that are sitting there that we can't touch because we don't have the manpower and structure to do that. But it's the same case types. So unprofessional conduct grew, quality of care grew. Which let's see, unprofessional conduct, yes. So quality of care jumped from 90 to 107 cases. That's 19%. Unprofessional conduct rose 46%. And then the 832 cases and inspections remain for assignment in backlog. So again, we look at the patient harm cases first. So these are some that may not be harm right away, but has caused some inconvenience to the victim there. So we really want to get ahead of those as well. So slide 14 will give the caseload for our investigators and kind of the average as it goes. So 185 active cases currently assigned to our investigators. Again, 832 that need to be assigned. So cases range from 30 to 180 days to a year to 2 years before they may have adjudication, depending on what the situation is and if federal involvement's there or another state agency or another local law enforcement agency is involved. So it just depends, but on average, 30 to 180 days, we have that case adjudicated and that medical professional knows the adjudication and the complainant knows the adjudication. So on average, 60 active case hours per case that the agents spend, and that's according to the cases assigned, that's 14.8 hours against an 8-hour day that they have to spend on these cases, and they do it. They work over to try to get these things done, but they're working over as well from the capacity they have. So slide 15. This is for our legal division. So we have one attorney. That's our Deputy Executive Director. She's out on maternity leave right now, so I'm acting as the attorney somewhat and trying to do the best we can. We do have a paralegal, and we're hiring an additional attorney in August using our retained funds, just so we have that position and able to alleviate some of these needs in our legal. What our legal office does is they oversee board orders, the enforcement and rulemaking side of things. They manage the OSA hearings that a lot of these cases have to go to. So Open Records Act, we get 5,250 requests opened since April 2025 for open request. We have to do those with that one legal and me helping as well, but these are coming more readily, more open records are coming, the more we're doing. So we know that's going to increase over the years. They also do the final board orders, consent orders, voluntary surrenders, any suspensions, any fines, any revocations. This is all administrative tasks they have to do after board meetings. So every month they have to do this. And they get behind on these things. And they also do the legislation. But we also have help from the Attorney General's office. There's one attorney that is assigned to us for board matters that have to go to the AG's office. So she helps out tremendously with us as well. We have 45 open cases in the Attorney General's office right now. And all that takes time, all that takes manpower, research, things to get done before the hearing. And that's kind of a list of things. I'm not going to go over everything, but it's kind of a list of things on the role of the Attorney General's office and GCMB matters. And our legal is also involved in that at the same time as the Attorney General's office. So slide 17, some of the accomplishments that we have done with the funding that was given to us and the technology and things that we have done. With ThoughtSpan, our licensing system, there's platform continuously enhanced. We launched a new newsletter to kind of get information out there because I think part of our duty is to educate. I think we missed that over the years. So Miss Perry is our communication specialist, and she's been doing a phenomenal job getting information out there to folks, letting them know rules and laws and kind of where we're at, what we're doing. So we're going to continue that. Next request, customer service, our open records portal, we were able to get that up and running. That helps because the phone calls we get, we're not able to answer all of them. This helps us be able to triage and I can see what comes in. I can't see a phone call. I can't see an email. So this helps us with our customer service request. The public outreach, like I said, we're going to places, we're meeting people where they're at. We're going to hospitals. We're going to clinics. We're helping them through the licensing process. We're helping them through whatever process they need that we're involved in. As the other agencies come up and said, we are working with them on several matters that affect our citizens and our patients. We're coordinating on the pediatric cannabinoid exposure work group. We met with the Poison Control, DPH, DFACS, and CHOA, and a few other associations to make sure that we're hopefully being proactive about it and getting others involved in the patient care issues that are in the state. And then we're doing these patient care focused initiatives, identifying issues with alternative medical practices, scope of practice issues with other licensed professionals that enter the practice of medicine, and identifying and enforcing unlicensed practice. So the Georgia Medical Board, and we regulate the practice of medicine. So other licensed medical professionals that we don't regulate sometimes delve into that practice of medicine, and then we have to get involved through investigation, but we have no regulatory authority over that other than if they violate the Medical Act. So we're getting involved in that to see where we can help. So slides 18, 19, 20, I'm just going to skip over. Those are just some customer service stats. If you want to peruse them and look at them and see what we get during the week, I'd recommend doing it because we do have a lot that comes in. Slide 21, that's our legislative priorities. So when I took over 2 years ago, I made an assessment to see where we're at with our current environment and what's needed. So I got with the board and we came up with these legislative initiatives. Some of you were involved in that, and we appreciate your involvement in getting these done. But House Bill 571, that's licensing of radiologist assistants. That's a new license for us. So we have to implement that into our system, and we also have to develop the rules that go along with it. And there's not many of those here in the state, but we're hoping this will bring more to the state to be able to help in that area. We did the psychedelic assisted treatment and IV ketamine therapy. That's going to be a new license for us as well, new rules. We're the first state to implement actual regulation on this, so we're kind leading the way for other states. It was a talk at the FSMB meeting to that this was a problem in other states, and what they're doing is researching things, and we just decided to go ahead and let's just go ahead and regulate it, and then we can work on that research later. But this way, we're ahead of the game with this in the ketamine clinics and the psychedelic therapy that'll come out. We had legislation on a limited provisional license for internationally trained physicians, which Chairman was involved in. And this is to help rural hospitals, rural settings. We didn't get the funding. We got the funding for it, but then it was rescinded during that money take back thing. So we're trying to look for, yes, sir.
Money take back thing. I like it.
Well, I didn't want to call anything out, but it was a take back. So we're trying to figure out ways of doing this without that, but it's going to be hard because it's a program that's going to have many hands in it to develop it, to make sure that we're working with the hospitals and we're working with the practitioners and we're working with the internationally trained physicians to make sure that all this meshes well. So it's going to take a lot to do this. We need a medical director to oversee it, to make sure that the people that are coming in meet the standards of what we need. So we need that oversight there that right now we're still trying to work on to see how we can provide that. There's a automated statewide credentialing verification system for healthcare providers. That was Senate Bill 162. We still looking for ways of doing that. We may try to get with Georgia Hospital Association or somebody to see how we can fund that to help get that in our system to help the state. But we have to have buy-in from the hospitals and medical professionals to do this. So that's going to take a lot of planning and implementation to get that done. And then Senate Bill 395, we have some medical cannabis where low THC was transitioned to the medical cannabis. We have a joint working relationship with the Department of Public Health on that. So we do the enforcement side. We make sure that the physicians are following the rules and laws, and DPH takes care of the actual program and the card. So this law was able to give us more access to things because we didn't have it before. So hopefully we'll start working on that with them, and we'll change our rules here coming up soon to match what the law says. So we're working on that. That's the current legislation. Proposed legislation for this coming up year will probably be some med spa legislation, maybe some registration type things, because we get a lot of questions. How many med spas do we have in the state? How many IV hydration clinics? We don't know. Nobody knows because there's no registration process. There's no way for us finding out. So that law may be hitting the book soon for y'all to review and hopefully sponsor, but that's something that the board wants to look at as well. Slide 22. These are just some of the rules that we changed this year, and some of the rules that we're going to be changing or adding to our system. So the rule 362.01, that's where physicians have to have a fingerprint check. That was already in the law. We were just able to implement it based on our technology, so we did that. Now that's in effect as of July 1st. So that's gonna take off, and so far so good with that. Position statements and development. I know y'all know we did a IV hydration statement, which caused a little controversy, but I think that's clearing up. We're working with both of those groups to make sure we're addressing that, and we'll get that squared away with them. We have a good working relationship with all the groups, so I think we're going to come out with something pretty soon that's going to address all that that we all agree on. So we're also going to do position statements on med spas and AI in Georgia, just so it's going to be based on current laws, not anything we're making up to be new. It's going to be based on current laws. So inspections, why it matters. If you go down to the next same slide, but at the bottom, what we've been finding on these unannounced inspections on these med spas and IV hydration clinics is unlicensed individuals providing services. So that's people that are non-medical and they're doing medical things. Medical directors with no training and laser modalities used. no training in the equipment they're using. So that's a problem for patients. Unlawful compounding of medications, that goes into the pharmacy board and their rules, but each IV bag is a prescription, and if you're meddling around with that, you have to follow the pharmacy rules. No supervised treatment, oversight, and medication sharing. We found some expired medication that people were giving patients, so that's an issue. No medication identification, amounts, or tracking of adverse effects. So if there were adverse effects, if they did go to the hospital and ambulance was called, what we're doing is we're gathering 911 calls to different addresses to see if that happened there or not. So we're doing a research to see what's going on with that. Staff practicing outside scope of practice and minimal written policy procedure manuals. So we have an issue there that we're trying to address, and we're trying to head it off with inspections. And inspections are just we're trying to get you in compliance. So if you're not in compliance, you're not really violating the law or hurting patients at the moment, we're going to try to get you in compliance. If you can't get in compliance, we're going to go try to figure out another route. So slide 23, one of those issues have been, and I'm not picking on the profession, this is just one that we've come across, is chiropractors doing IV therapy, testosterone, and GLP medications out of their office. Well, chiropractors can't pierce the skin or inject anything. They don't have prescribing rights. So how are they getting this? What are they using in this situation? So that's just, we have a lot of professionals that are doing this, but that's just one that we're seeing a lot of. Unsupervised injections carry infection and dosing risk with no physician oversight, no screening for contradictions, so no medical exam to see if these things they're providing are going to cause any adverse actions. No DEA registration for the controlled substances. So where are they getting them from? So, we look at unlicensed practice. That's part of unlicensed practice, and we'll look at that with our investigators. But that's just part of the issue that we've seen throughout the state that we're trying to address with the staffing that we have. But we know we're going to need more. And I know y'all always hear it all the time. We need more. We need more. But I'm just one of those that I'm going to take care of my folks, and if they need it, we're going to request it, and we're going to and I'm going to give you the stats and information that's going to show why we need it. But so slide 24 will show the positions that we feel we'll need to be able to accomplish our goals and get where we need to be able to, for patient care and patient protection, and make sure that we're providing the service that we're paid to do. I'm not going to go over all this, but if you'll read, you'll see kind of the reason why we need some of these positions and how they'll help. So slide 25 is I know we have some of our budget committee in here, so I just want to go over that briefly. We brought up options last year, and I think these options still stand as far as a good path forward, because I hate to bring a problem without a solution. So I'm going to try to bring a solution to this. So our solution is, we retain 80% of our fees that we get, and then we'll be able to accomplish our goals.
You're not saying you do that now.
No, I'm saying if we get 80%,
get,
right now we get about 40%. But if we get 80%, we'll be able to accomplish our goals and not ask for anything else, I think. And then another way is for us to increase our renewal fees for our licenses. We did a UGA study, which I'm not going to go over, but I think that was provided to you all. It kind of shows other states and their fees. Georgia is the lowest as far as renewal fees in those states. So we don't want to cause a burden to our licensees, but we feel that if we could increase that minimally, so every 2 years, it'll be about $93 a year just for physicians, because they're I think the highest renewal. It'll be $93 a year extra that will be charged for that renewal fee. But each of our 12 license groups will be different, but we have that for you on the next slide. It'll be to show you what our comparison is. But that's an option for us to be able to retain those fees and also be able to provide that service without causing too much of a controversy with our licensees, I believe. And the next slide, 27, that'll just go into the study again that UGA did to kind of show you what the license fees increase will do and how it will help with the money. So that we would need to hire our extra personnel. So not going to go over that too much, but it'll give you the cost estimate that we will bring in based on that renewal fee. And then slide 28, I'm almost done, y'all. Slide 28. So what happens if GCMB doesn't get what is needed at the time to progress? Backlogs keep compounding, patients remain at risk longer, licensees face longer uncertainty, and Georgia loses ground it has already gained. So I think we have, at GCMB, we've gained a lot of ground on what we're doing. I think we want to continue that progress. And you have folks that work at GCMB and the board that want to do that. So we're ready to work and we're willing to work to make sure we keep up with that demand. We just ask for y'all's consideration in this presentation, and I guess any questions you may have, I'll be happy to answer.
Thank you for that presentation. I know we have some issues that are out there. Obviously, there's been some news reports kind of implying that there maybe needs to be tighter oversight of physicians. You talk about scope of practice, and some of the things being alleged is that people are doing stuff either outside of their specialty or outside of their training or frankly outside of accepted medical practice. And staying on top of that does require some diligence. And let's go to Chairman Taylor.
Thank you, Mr. Chairman. A couple great information here. I've got a lot to look at.
Yes, ma'am.
Do you have any idea what's causing the increase in the number of investigations?
Yes, ma'am. So our triage process and then our case management process has changed. So it doesn't necessarily equate to more issues or more violations. It's just how we're getting those complaints in and how we're triaging them.
Is it more opportunity for people to get a hold of y'all, or is
It is. It's our public outreach that we've been doing. It's our new complaint system. It's easier for folks to be able to do it. It's become easier to get complaints. So we're getting more, and then we're opening more because previously the triage wasn't set up to address all of the issues. So now that we're addressing all the issues.
triage it first and then decide where it goes, what
Yes, ma'am.
category?
Yes,
And if I could follow up, what penalties are there and how many do you actually transfer to the AG? Can they give you more assistance, or y'all have to triage them first, get the case quote put together and then transfer it to them?
We do. We have to work the case completely before it goes to the AG's office. And what happens is in our compliance division, let's say complaint against a licensed professional about quality of care. We gather those medical records. We gather any witness statements, any statements from the practitioner. We gather everything, any pictures. We send that over to the committee, whoever the investigative committee. They'll look at it and they'll say it needs to go to peer review, our medical director. So we send it to them for them to do their medical opinion. And then once that medical opinion is done, then it goes back to the board for them to decide on action. And if it needs to go to the AG's office for any action on the license, then it goes there. The board can take action itself during the board meeting and say, we want to fine, or we want a letter of concern, or we want to close. So there's different avenues they do. And as far as how many board actions were issued. So 2026, we had 85 public board orders, 24 private board orders, and 110 letters of concern.
It's increased a lot.
It's increased, yes, ma'am.
Yeah. And on another issue having to do with the license, I know we do a lot of recruiting. We're growing our own docs, and the time to process has increased, and it's because of the volume, I'm assuming. And we need to get these doctors licensed. I get calls from my local folks.
Oh, yeah.
That they need it, and it's really a staffing issue. And just on that same note, how long has it ago was it the last time that we increased the fees that we charge the various providers?
It's been a while. It hasn't been since I've been here, and I don't think it was my predecessor either. So it's been a while. So we're reviewing that now just to see.
All right, thank you.
Yes, ma'am.
Chairman Leverett.
Thank you, Mr. Chairman. Thank you for testimony. It was very, very detailed. I appreciate this. So you used the term compliance earlier and distinguished it from other things. Is that a broad term you use for enforcement as well as routine inspections? Or when you say compliance, what specifically are you talking?
So when I first got there, we had an enforcement division. Well, like enforcement, I think we need to keep people in compliance. So we changed our division to compliance, and what we want to do is maintain that compliance by our rules and laws. So our compliance division, they work off our rules and laws, our rules basically, and then our investigation section is also a part of that compliance, but they deal off the laws more so than the rules. So it was just to change the verbiage a little bit from enforcement to compliance.
So is one division ensuring that people are following requirements imposed by reg, and the other is dealing with requirements imposed by statute?
Yes, sir.
Okay.
Yes, sir.
All right.
Because they get to go out and investigate. They're full law enforcement officers, and then our compliance investigators, they're in-house, so they stay phone calls, emails, that type of thing. Gather information.
Is chiropractic subject to your jurisdiction as well?
No, sir. That's under Secretary of State, and they have their own board.
So how do you learn of violations by chiropractors? Do you inspect them, or do you get referrals from?
So we get complaints about other professions doing the practice of medicine. So that would fall up under the unlicensed practice.
So it's more from like a doctor calling about something he's hearing that rather than someone calling saying, my chiropractor done give me a shot and it's blowing up bigger and hell, it's itching and red. You don't get that sort of thing.
We get that too. We get both of them.
Okay.
Yes, sir. But a lot of them come from practitioners, and a lot of them come from patients who had adverse reactions. They just didn't know who to go to. So they'll send it through us, and we'll look into it.
Okay. And just, I apologize because my questions show that I'm not on the health committee because I'm asking very fundamental. But so you're a board. You enforce, not your term, but that seems effectively what you do. Statute as well as rule, and you have rulemaking authority as well.
Yes, sir.
Okay. All right.
Yes, sir.
Thank you.
Yes.
Thank you, Mr. Chairman.
I want to publicly thank you for all that you've done. I know you've been working really hard and overtime, and you and I have had discussions on Saturdays and probably late Sunday afternoons. I just want the committee to know that Jason has asked for 25 positions in the last 2 years, and he got 4. So maybe we need to look at letting him keep a little more of his licensing money so he could have the manpower to run this composite board.
That is certainly on the legislative options. Chairman Powell.
I'm kind of amazed that I've dealt with a lot of issues in a lot of departments.
Go ahead. Hit your button again. Try it now. Use Chairman Hawkins or the next.
Number 29.
All right, go ahead.
I'm 27.
Can you hear me now?
Yes.
Yeah, I'm kind of amazed, and I want to thank you for your presentation. I've been in the legislature a number of years and dealt with a lot of the regulated industries and all. And I swear I did not know y'all meddled with as many things as y'all meddled with.
Yes, sir.
And that's really about the only way I can say it. I got a number of questions, but I'm going to try to stick to my original questions. For several years, I've been active in promoting APRNs and PAs and their relationships under protocol with docs.
Yes, sir.
That we have a problem in this state. We don't have enough doctors. You got some areas in the state where you don't have any doctors. And folks have to go, and I've passed legislation with the help of my good friend, the chairman. We've dealt with legislation on APR and PAs and all, and prescriptive rights and such. And then I get irate when I come back the next year and it hasn't been enacted because of rules and regs is what I've always been told. And then, of course, what I'm seeing now is it's under the protocol agreements. And I think y'all have had some issues with APRN protocols as of late in the last this summer, I'm thinking. Can you tell me a little bit about what's going on with the protocol agreements and the holdups? I know that nurses don't fall under y'all's board.
Yes, sir.
And there's been a lot of accusations, if I may say, over the years. You got a board that's dominated with 13 physicians and only 4 other folks. Nobody else has a say. People tend to believe that y'all are just a handmaiden of the doctors. So tell me a little bit about where your protocol agreements are.
I can. So when I first got this position, I was approached about APRN protocols and the time it took to get them approved. So that was one of my first agendas, was to work on APRN protocols, because I saw that it did take time. It was a paper process then, which was horrible. So we moved it to the electronic process. So since the electronic process, we have 25,951 active protocols. So we probably deny less than 6% of protocols. And those denials are based on specialties, based on location of the physician, and a few other things that fall in with the rules. So with the protocols, we've actually, since we took over, the approval rate was 250 a month. Now we're up to 900 a month. So we're approving more APRN protocols. We're putting more APRNs to work with physicians since that time. So I don't see I don't think there's an issue anymore. I think what happened with the position statement was things were taken out of context on that. And so what we were trying to do was reiterate law that had already been there, so that folks who were getting into business would understand they've got to follow certain rules. And we're adapting that now to try to fit the current environment. So I think our board has since I've been there, they work on every aspect of it. So we have an APRN committee that has APRNs on it that make these decisions with the physicians. So I think it's a fair process. I don't think there's anything that we're doing that's not the fair. And we're listening to what's happening, and we're listening to the current environment of practice and seeing what we can do to help with that. So I think we're providing the board more information than they've had in the past on certain things, and I think that's helping alleviate that concern as far as physicians taking care of physicians. I think that's not happening since I've been there. I think it's a good board. We're approving more protocols. We're putting more APRNs to work. We're just making sure that our physicians are doing the proper supervision and the things as well. So it's kind of working with both of them to make sure both of them are doing the right thing. So it's been a work in progress. This past month, showed me some things that I didn't realize was going on in the state. So now that we know things are going on, we're trying to figure it out and work with both the APRN Association and the Medical Association of Georgia. They're working together to try to figure out this solution. So I think we're proactively working on things to make sure that we're working with others and not just saying this is the way. But we have to go by our laws and rules that we currently have too. So hope that answers.
It does, and I want to thank you for that.
Yes, sir.
Some of us have been outspoken for years about, those people in Georgia, a lot of them that don't have access to physicians. They really don't care if you got a doctor or a PA or APRN in front of your name, as long as they're getting treatment or getting the necessary care that they need. And, my good friend, the chairman, we've worked on some things together, and, there's a fine line between, water runs downhill. Most of us tend to believe that the ultimate decision rests in medical issues to a doctor. Then you've got the others, the PAs and APRNs and all, that are well educated. But some of us, there's people like myself that I favor nurses because they're the ones that keep the doctors from killing the rest of us.
I think I've heard that before.
And, I'm gathering information.
That for the benefit of the chair.
Thank you, sir.
But I want to thank you for your comments. I would like to ask you something about, you're talking about being underfunded, and
Yes, sir.
I listened to you very intent as you went through all this stuff. I've been active in the medical cannabis stuff a number of years since it was originally passed. And I noticed that y'all are involved in the low THC oil.
Yes, sir.
To what extent? Because we've got other agencies. We've got the Department of Agriculture that monitors all that with a full staff. We've got the medical marijuana
commission,
board, whatever they call it.
Georgia Cannabis Commission, yeah.
Cannabis Commission and all that. So now we've got a third agency.
So we've been involved since the beginning. The issu's been is our access to the information. So we make sure that the practitioners are following the rules for what they're practicing and how they practice with the medical cannabis. We don't get involved in the degree of medical cannabis or things like that. We just make sure that the physician has a patient relationship and that they're treating that patient for the proper condition. That's where we come into play. And the problem we've had in the past was we didn't get that information shared with us, so we weren't able to proactively address this and make sure that patients were safe when they're getting this treatment. But now that this new law come into effect and we get to share information, our DPH gets to share information with us, we're going to play a more active role just in the physician's area. So we don't deal with the medical cannabis itself or the cards themselves. We just deal if the physician and the patient have a relationship, because we've had a lot of out-of-state physicians who have a high patient load who may have never seen a patient. So we're addressing that, and that was addressed in the law too to keep that from happening. So we noticed some issues that we're trying to address now, but we're involved with the practitioner and the relationship with the patient.
So the way the Georgia law is written, that physicians can issue if a patient has one of a number of diseases or conditions and such, that doctor then can issue the certification to go to the health department to get a medical cannabis card.
Yes, sir.
So y'all are actually checking the physicians to be sure that they're giving that written permission based on bona fide illnesses or conditions.
And relationship, to make sure they're not just fly by night. You call a number, you get the card. Make sure that's actual medical care being provided. That's where we're involved. We're not going to stop it if the physician says this is what treatment they need. We're not looking at that. We're just making sure that it's a legitimate need and treatment is being provided and that relationship is there.
Thank you.
Yes, sir.
Appreciate you following up on that. I know in regard to the earlier issue, I know our APRNs are a vital part of the care we're given. Like you say, though, it is a team sport in a lot of ways, and our patients do have certain expectations. I believe I've read that the APRNs are up 40% in Georgia over the last 5 years and expected to go up another 58%. They'll be vital team members. I think patients can get care from more than one level, but it helps when there's a team approach that has a senior supervisor. Chairman Taylor, did you have a question?
Yes, thank you. All this discussion about scope of practice and licensing, it dawned on me do we have a special license for autism therapy? Does there need to be one? Or do they operate under the auspices of a physician? I'm concerned because that's a high dollar area. We're seeing a lot of money spent that way. And is this something we need to look at for a license?
I mean, we're willing to
And
do what we need to
criteria.
do.
We're going to have to invent the criteria and the training to have it, and then you would be able to make sure that it is a licensed person providing this care.
It could be us or it could be a board on its own, but I know we're willing to do what we.
Concerned because it is a high dollar cost, and I can't find any regulations that address it, but it might end up in your pocket. Thank you.
We'll take it if we get some more funding for it. We appreciate it.
Thank
You get that extra duties.
Yeah.
No, I want to thank the committee for your participation. I thank everyone, whether you're here or not, still, and thank you for your presentation
Yeah, thank you.
on behalf of the Georgia Medical Board, Composite Medical Board, and all the areas that you help oversee and assure that we can feel safe when we walk into a medical office or a hospital or day surgery center, that someone is doing the compliance assurance that you and your team is doing. So thank you for doing that. Thank you to everyone. We will have our next meeting in Augusta, August 12th. So you'll be getting more official notice about that, and we'll be in Macon in September, but we'll get more of that out later. Thank you all for being here. The meeting's adjourned.
Thank you all. I don't mind at all. I think it's good.
I took a lot of statements today. When they said, I mean, the phrase that I'm living with now is